Good morning, ladies and gentlemen. Welcome to the second National Healthcare Conference, the Knowledge Sharing Platform for Nurses and Midwives. This is the second of our 2 days, and it will be divided into numerous sections where we will have 5-minute breaks. And what we'd love for you to do during those breaks is to post on all social media platforms using NHCC Uganda. So be that Instagram, Twitter, Facebook, LinkedIn, etc. So let's get this really on fire on social media. Please, though, mute your microphones and stop your videos. And that is unless you are one of the presenters. This is to allow us to keep the bandwidth stable. Good morning, ladies and gentlemen. Welcome to the second National Healthcare Conference, the knowledge sharing platform for nurses and midwives. So you are now welcome to the second day of our annual conference, the second one that we've had. We are going to have some 5-minute breaks in between the different sessions. And what we'd love you to do, if possible, is to post on social media using NHCC Uganda, be that on Instagram, Facebook, LinkedIn, or Twitter. So let's get the internet really aware of, the great work that's going on in nursing in Uganda. Please can we ask that unless you are one of the presenters or speakers, that you mute your microphone and stop your video. This will allow us to keep a stable connection so everybody can enjoy the presentations. So we are going to start now. First of all, we are going to have the opening stanza of the Ugandan national anthem. Second, we're going to have the nurses anthem sung by St. Mary's Midwifery Training School in Kalongo in Uganda. And then third, we're going to be led in prayer by Ms. Winnie Nakamanya, who is one of our NHCC Team 2020 volunteers. Thank you and have a fantastic day.
Ladies and gentlemen, let's salute for the Uganda national anthem, first stanza. Now let's observe the Uganda Nurses and Midwives anthem.
Okay.
We have been chosen.
We have been chosen.
Chosen by God.
Chosen by God.
Chosen to be nurses.
Chosen to be nurses. Our holy people to love and serve. We have been chosen. We have been chosen. Chosen by God. Chosen by God. Chosen to be nurses. Chosen to be nurses. Our holy people to love and serve. Come on, nurses, to the God of true salvation, to the Spirit that makes our lives new. Come on, nurses, to love and serve. We have been chosen. We have been chosen. Chosen by God. Chosen by God. Chosen to be midwives. Chosen to be midwives. Our holy people to love and serve. We have been chosen. We have been chosen. Chosen by God. Chosen by God. chosen to be midwives, chosen to be midwives, our holy people, to love and serve. Come on, midwives, to the God of true salvation, to the Spirit that makes our lives new. Come on, midwives, to love and serve. We have been chosen. We have been chosen. Chosen by God. Chosen by God. Chosen to be nurses. Chosen to be nurses. Our holy people, to love and serve.
Let's humble ourselves for the opening prayer.
Okay, yes. Good morning to you all. Let's humble ourselves for prayer, please. In the name of the Father, and of the Son, and of the Holy Spirit. Amen. Oh, loving Heavenly Father, we come to this hour asking for your blessing and help as we are gathered here. We pray for your guidance in the matters at hand and ask that you would clearly show us how to conduct our work with a spirit of joy and interest. Give us the desire to find ways and excel in our work. Amen. In Jesus' name we've prayed. Amen. In the name of the Father, and of the Son, and of the Holy Spirit. Amen.
Thank you very much for that. That's fantastic. So next we are going to have a recap of day one. So we're going to look into the background of the National Healthcare Conference, Uganda, and that is with our founding chair and nurse, Mrs. Elizabeth Pearson. After that, we're going to look at the importance of advanced nursing training in Uganda, and that session will be with Dr. Safina Museni, Commissioner of Business, Technical and Vocational Education and Training, so BTVT, and Chair of Nurses and Midwives Think Tank. So over to you, Elizabeth.
Hello, good morning, and thank you for that. Can you see my screen?
Yes, we can.
Thank you. Welcome to day two. I am Elizabeth Pearson, and I am delighted to welcome you all on behalf of to the second National Healthcare Conference Uganda, the knowledge sharing platform for nurses and midwives. I am a qualified adult nurse, passionate about world development, and I want to take part in many things with the knowledge and experience I have gained over the 18 years that I have lived and worked in the United Kingdom. I am particularly keen to promote specialist fields in the nursing profession. Due to the current pandemic, we are having our second conference virtual. It has proved to bring so many colleagues from all of the corners of the globe and to share learning. It is an excellent opportunity and experience. Right now, we've got over 400 participants registered. So I'd like to give you 3 reasons why we are here. We are here today because we believe that once we, nurses and midwives, are equipped with the knowledge and skills, we will be empowered to take part confidently and accurately in those crucial decisions regarding patients' care. Hence, care delivery will be improved. The second is to join the rest of the world in this campaign to raise the profile and status of nurses through knowledge sharing. Other groups have done various activities. So I encourage you to meet our coordinator, Madam Catherine Odeke, if you have any event that you think can raise the profile and join the campaign. So we believe history was made yesterday when our colleagues presented their research and project findings aimed at improving care on what became an international platform. This is a historic moment and we should be proud of it. We are also here today to enhance and promote specialization in nursing. You heard the Honorable's speech yesterday, if you attended, that modern nursing has over specialized fields. This platform is for us as individuals and maybe as teams to realize and identify these key areas of interest so that once new skills and tools are shared, we can go ahead back into our clinical areas and pursue these. This will enhance and create champions and link roles in those different fields. I am sure that many of you, like me, would love to become a wound care specialist and gain more in-depth knowledge from Dr. Serena and his team to help us join that set of specialization. By the way, if you are interested in wound care and tissue viability, please email me and we can discuss this. So that is our journey so far. We are having the second conference. So today is the last day of our conference this year. And we are delighted to have part 2 of the keynote address from Dr. Serena again. To learn more about the Nightingale Young Leaders from Dr. Hanaway, how nurses can strengthen the healthcare system from Professor Omaswa, and why we should advance by our Commissioner, Dr. Safina Mutene. We would like to thank all our generous speakers who have taken time to prepare and share their knowledge with us. This is why we are here, to gain skills, competences, and tools. How are we doing this? Is by outsourcing those experts in different specialist areas, raising our profile, and promoting world health. We have heard that over 100 specializations. There's a new one, bariatrics. I don't know if you've heard about it. Get involved, learn more about it. Dermatology nursing, and so forth. How and why and why are we really doing this? This is a stage 4 pressure ulcer that my late grandmother suffered, unfortunately. Something you would see on the ward and you would term it as a chiwundu in the local language, but it's not. It is just skin breakdown. So with skills, competences, and tools, like we see in this slide here, we would be more equipped to manage this skin breakdown confidently, and therefore do not end up having our patients to suffer longer than expected. The benefits for an individual is we get an expert, where our care delivery is improved, we are confident, and guess what? We'll be marketable. When we go to those applications and those jobs interviews, that specialist care, having that specialist knowledge is really important. So what are the benefits for your practice if we have any line managers on or any of our executive directors? We'll have confidence that we have been trained by experts. The standard of care received will be different. The hospital stays will obviously be shorter, and in some cases, there'll be less risk of infection, because we know when patients come in and stay longer in a hospital, the risk of acquiring an infection along the way goes really high. So with the appropriate training of our healthcare providers, my grandmother and many other vulnerable patients do not have to suffer in pain from these complex wounds and pressure ulcers. With appropriate training, knowledge sharing, what we are doing here, these can be mitigated. It is simple things that really count. So I have here a nurse, Linda. I don't know if we have any Linda in the audience, but her and her colleague maybe run a clinic at a health center in Mukono. After attending these conferences, we are hoping that Linda would be equipped with new skills and knowledge She's on phase 1. She's able to assess and manage her patients who have pressure ulcers and those who present with complex wounds. She will assess them, do her documentation, and follow up with her colleagues through a network that she would have created. What would happen when she returns to work on Monday after the conference, seeing today is Saturday? I'm sure she'll be more confident. She would have learned a little bit more. And obviously, the care she delivers will be different. So I would like to, at this point, acknowledge, allow me to acknowledge Lady and Honorable Minister of Education and Sports, and Honorable Miss Rosemary Seninde, her representative, the Permanent Secretary and Ministry of Health team, including our new Commissioner of Nursing, Mrs. Beatrice Amuge, His Excellency, the Ambassador of Uganda to the UK, Mr. Julius Peter Moto, who has continued to support us actively. I remember now a couple of years when he agreed to meet us. I shared with him this big idea. He was very supportive and encouraged me, and he continues to. He said, and I quote, "Knowledge not shared is useless knowledge." Thank you, Your Excellency. Many thanks and appreciation to our nurse and midwifery leaders, including our retired but not tired generals. Our Commissioner, Dr. Safina Musene, Mrs. Odeke, our new Commissioner, once again, Dr. Catherine Hanaway. All these are our leaders, nurse leaders, both in UK and in our patron, Dr. Rose Clark Nanyonga, the Registrar of Uganda Nurses and Midwives Council, Miss Angela Ilakut, our Chief Judge this year, Miss Rose Chiwanuka and her team, and all our leaders, including those in training institutes who have really paved the way for us. I would also like to thank our stakeholders who have made this second conference a reality. The Ministry of Health again, Seed Global Health, Shirley Bales, the chair and board, the chair board of directors at Barnard Trust of Nursing, Uganda UK Health Alliance, Dr. Mwange, and mainly for this conference, the IT lead, Mr. Timothy Odonkara. Thank you so much, Timothy. The Commonwealth Nurses and Midwives Federation, the National Healthcare Conference Board members, Zone 1 Hearing, Nursing Now Uganda team, JAPEGO, ICN, the World Continuing Alliance, Education Alliance that we are going to hear from, Moorfields NHS Trust, CIFOVID Uganda, the Uganda UK Health Alliance, the iHealth Uganda, and our young nurses and midwives, the Nightingale Challenge. I would also like to thank the hospitals, the management, the at these regional hospitals for coordinating our clusters this year. Miss Winifred in Hoima, I think because of diversity and inclusion, we now refer to all as Mrs. and not sister. So Miss Winifred in Hoima, Miss Gladys in Fort Portal, Miss Judith in Lira, Miss Susan in Arua, Ellen in Imbale, Miss Namusoke in Lubaga, Miss Anasuna Benedict, Miss Nabanja and Mary Grace from Kawempe, and Miss Tino at UCI from Mulago area, Miss Katusime in Imbarara, Miss Phoebe and Josephine in Iganga, and Miss Barbara in Masaka. Thank you so much for your coordination and for your leadership. Last but not least, for those who are going to present their research today again, thank you so much. For those who sent in your questions already, and for those who are participating, joined us on this virtual platform. We enjoy the conference, but more importantly, that you will live enthused with new skills, and contacts to take back into your practice. So lastly, allow me to introduce to you the National Healthcare Team 2020. They will wave and say hello as I call out their names. Hopefully everyone is awake now. Miss Tracy Kamau, our timekeeper yesterday. Tracy. Miss Primrose Magala, one of my mentors and coordinating this conference. Nakamanya, who led us in prayer and also presented an excellent nurse-led project.
Yes, I'm present, but my video is off.
Oh, thank you.
Yes.
Miss Jackie Ijokorain, our timekeeper for today. Miss Harriet Naiga, helping coordinate and publicize this conference. Miss Barbara Tumusime, our PR advisor. Miss Diana Kahunde, our marketing coordinator. Mr. Oscar Muhumuza, our moderator. Mr. Timothy Odankara for IT and coordinating. Mr. Matthew Pearson, our MC. And for some who prefer to remain anonymous, thank you, thank you, thank you. We have had an amazing team and have pulled off our first virtual but second conference successfully. Thank you very much and looking forward to shared learning.
So thank you very much, Elizabeth. That was fantastic. Next, is it possible to have Dr. Safina to speak? Really looking forward to hearing your session. Thank you very much, Dr. Safina.
Thank you very much. I wanted to project my presentation. I'm trying to project and it is not upcoming.
Is it possible to adjust your screen slightly because we're just getting the top of your head and we'd love to see you?
I was saying, is it possible for me to project my screen, to share my screen?
Let me just check with our technical people and find out for you.
Okay. Okay. Are you able to see my screen now?
Yes, we can see your slides.
Okay. Good morning, ladies and gentlemen, and I want to thank the organizers for really organizing this conference and inviting me to make a presentation. As a Minister of Education and Sports, we don't take this for granted. We see the effort and everything that have been put in to see that the education of a nurse and a midwife is improved. Members have already been introduced. I'm Paul Safina Kisumusene. And in this presentation, I want to use 1 minute to say that, yes, I'm a nurse who has grown from a stage of being a student to a junior nurse. I will not say that. I was not talking about the concept of nursing, of advanced nursing education, the importance of advanced nursing education in Uganda. And I just wanted to say the definition that I got from ICN. This definition says that it is a system that produces nurses with expert knowledge base, skills in complex decision making, and clinical competences for expanded practice, which are based on the scope of practice. The literature that I read, it shows that this trend started as early as 2000, and it relates to a type of a graduate who is at a level of master's and above. Definition relates to an anesthetist, nurse, midwife, or case manage, that all denotes to the above concept. Who is this nurse practitioner? He is a registered nurse who has completed a master's level, as earlier I've said, and is practicing advanced nursing and advanced practice training. She can see a wide range of patients, both at well and sick levels. She can perform in office procedures. She can order and interpret tests, admit and discharge, but also can conduct, cannot work in isolation, can consult, and can also refer according to whatever she's doing. And such a nurse, as earlier said, requires an advanced nursing education. Importance of this advanced nursing training in the country, I've looked at it in a way of relating to Uganda. And I've asked the question, why do we need advanced nursing training in Uganda? And I have 9 areas that I'm basing on to answer this. One of them is that up to date we still have very few general practitioners, and sometimes they are not willing to go and serve in unserved areas, like the rural settings. They want to concentrate within urban areas, and that always make our clients in the rural setting remain unattended to. We all appreciate that recently Mulago National Referral Hospital was expanded to a specialized hospital, and making provision and establishment of various specialization, and all this will not need such a nurse at an advanced level. We have introduced the female hospital at Mulago Hospital, and this provides for highly specialized services in obstetrics and gynecology, including management of fertility issues and infertility issues, and all this again will require such a person. We have expanded, most have intensive care units, most of them have mental care units and other services that require a well-prepared nurse. We have created additional services. Before, for some of you who are not in Uganda recently, we do not have a department at Ministry of Health Support and Ambulance Emergency Care Department. But right now we have such a department, and that is another reason why we have to think through. Now, we are seeing many conditions coming on, very complicated, highly infectious, COVID-19, Ebola. We are seeing a lot of increased occurrence of non-communicable diseases, diabetes, hypertension, cancer, and the rest. We are seeing many Ugandans, because of improvement in service delivery, increasing every day is increasing. We now have citizens, and they require such services. We have invented highly sophisticated technology that again will require a nurse at that level to manipulate. And this takes me to why we require such, the importance, preparation of an advanced nurse practitioner or specialist is important. Respond the above issues that are raised. It provides an opportunity based on assessment, diagnosis, and interpretation of tests. And this type of a nurse can independently prescribe medication and evaluate the treatment and even refer if necessary. Getting on. I have just made this list, but not limited. As I was listening to Elizabeth, I had her mention other areas also. We have oncological unit or hospital in the country, and we are proud to be hosting a center of excellence for oncology in the whole of East Africa. We have the emergency and critical care, so we need nurses in those areas. Cardiology, again, have a full hospital for that at specialization level, at postgraduate level. Geriatric, I've already told you, we need such nurses. We need ENT. We need diploma. We need nurses in education to the clinical practice. Themselves, they need to be at that level before they prepare others to take over. Public health is another area, and COVID-19 proving this to be necessary as true. Psychiatry, many are coming up, and we need. Yesterday, in the minister's presentation, we had that we have over 100 specializations that we need to focus on. With such education and the person that we need the challenges that are likely to be faced by education are still trying to understand it. And therefore, as leaders, as nurses, we need to go ahead and sensitize all of us to appreciate that concept. We have limited opportunities and an availability curriculum for such nurses. And therefore, as education, again, we have to develop such curriculum, but getting the need from the world of work, and for our case, is the Ministry of Health, is the nurses, is the service, the people who receive such services that will demand for such a specialized person. We need to accept the need for such education, and then this brings on the regulators, the service providers, and the educators, all of us. We need to accept that person. We need to get regulation of that person. I'm not sure whether the professional council is already of a person, and I'm not sure whether this type of an appropriate remuneration compared to the jobs that equal to such a person. In conclusion, moderator and all nurses and midwives attending this conference, I want to say that it is now time for Uganda to develop nurses and midwives with capacities to provide evidence-based practice, service transformation, and implementation of new strategies in managing patients and healthcare workforce. We need to have practitioners with advanced nursing, leadership, and management skills. Please support the agenda population for such a population. Why am I ending with this last caution? Is because in most cases, we tend to ignore. I want to look at the science who are the graduates to be catered for, and I want to see the advanced practitioners also clearly catered for. Before I made this discussion, I discussed with my director, and according to my study, I observe population of nurses in Uganda and look for avenues to support such education. I thank you and I submit.
Thank you very much, Dr. Safina, for that fantastic presentation. Very encouraging to hear about the advanced nurse practitioner role. And, you know, we hope more nurses will look to apply for that kind of role. So thank you again so much. Apologies for the slight technical hitches we had there. A little bit of an issue, I think, with the internet connection. Anybody who's not presenting at the moment, could we just request that you do turn off your video just to help us preserve that? Thank you. So next we're going to have a presentation about the nurse's role in strengthening healthcare systems in Uganda. Now this is by Professor Francis Omaswa, who's a cardiologist and keen supporter of the nursing movement. So the professor is an executive director of the African Centre for Global Health and Social Transformation, so HS, and NNC Executive Board member. So thank you very much, Professor, and over to you.
Good morning, everyone. You can hear.
Good morning, Professor.
Good morning, all. Good morning, all, and congratulations on putting up this meeting. I was not able to participate yesterday, but I am here today. And it is an exciting time. Should I start my video? Do you want my video? No.
Yes, we need it.
Yeah, yes, please, sir.
All right, I hope, okay, you need to see what I look like. Why not? Okay, I hope the connectivity will enable it.
Thank you.
Right. Yes, it's an exciting time for nursing. We are in the year of the nurse, 2020. Corona has intervened and applied brakes on what we want to achieve, but still we've extended the activities to next year, June. But here in Uganda, this Nursing Now campaign is really provided us with an exceptional opportunity to kickstart the transformation that we desire for nursing to be able to make a major contribution to improving health outcomes in Uganda, achieving sustainable development goals, and of course strengthening the health systems here. And we see it as an opportunity to, of course, raise the profile of nursing, their recognition, and the critical place that they play in the health system of the country. I always point out that it is not just nurses growing their egos, but it is about all of us health professionals, especially we in nursing, making a bigger and stronger and yes, a more visible contribution to the health of our people. It's about our people, it's about our people, and it is not primarily about us. So we held a retreat at the beginning of 2018 here. In preparation for this meeting, I went back to read that report. It is beautiful, the report of that. We made a strategic plan. So I would like us here in Uganda to do everything possible to implement what we decided to do as part of this effort. Let's look at some guiding principles, how we are going to implement this strategic plan and achieve what we want to achieve. Number one, let's appreciate that we work as inseparable interdependent teams, that's the health professions, in which each profession has a defined role and which reciprocally supports and complement each other. We all work together as equals and we focus on delivering care to our communities and the people. And here in Uganda, what I see now as the key interventions, the key gaps that we have, number one is leadership of the profession. That has been a problem for a long time. We are divided, we are fighting, and so on and so on. And then for a long time, we did not get a substantive commissioner appointed in the Ministry of Health. That was not good. But now we have a new opportunity. We have a brand new commissioner, and we should work with Beatrice Amuge and let her be our coordinator inside the government to make sure that our aspirations are all achieved. Number two, we have the new opportunity of the creation of a federation, a Nurses and Midwives Federation. You know, some years ago, a disaster occurred here in Uganda. Somebody from outside came and said, you don't need an association, let's just have a union. I will give you money if you do that. We did that and it's been a big disaster, but the association is back. All those groups which we've been talking about, the specialized nurses in cardiology, in ENT, in whatever, will all be coming together to have one powerful group, which ensures that the quality of nursing in the country is to its best and we are accountable to our people. So that I'm looking forward to getting that federation rolling. And then, of course, we come to the Nursing Now campaign and the strategic plan which we have made. We should use that strategic plan to acquire the competencies that we need to be leaders. We want to be leaders in the areas where we practice, but we want to be leaders also in those places where we can influence so that our work, wherever we are, can get done. We want to be in parliament, we want to be on the tables where all the decisions are made, but to be able to be invited and to take our places on those tables, we need to acquire competencies, qualifications, and so on, which take us there. We are talking about those clinical qualifications. I also want to see qualifications in leadership and governance, in management, in corporate governance, and so on, so that we can be there where these decisions are made. Then we use the structures. The structures in Uganda are there, but we just need to get to use them. We have reformed the district health system in Uganda. There are very clear roles for nurses over there, and we just need to prepare those people to play those roles and be practical with homegrown solutions. So I want to advance one opportunity which we can assign to nurses to take leadership in transforming the health of the people of Uganda. Integrated, people-centered primary health care. I saw in the strategic plan, there was a complaint that as a weakness, it was recorded as a weakness and a threat that community health extension workers who were coming on, village health teams and so on, were taking away the work of nurses. I don't worry about that. You know, let's just make sure that where there is a gap and we have skills to play those gaps, we are there. I think that's the justification for the last presentation, because all those things which that advanced nursing practitioner is expected to perform are the ones which already clinical officers and doctors are doing. But the gap has been identified and it is being filled. But here, in integrated people-centered primary health care, there is a tremendous opportunity for nurses. to become the leaders. And to me, it is the quickest way to achieve SDGs. We have been, there are nurses who are home visitors and domiciliary services and all those things which community nursing, community health, public nursing can play a role in. I really would like to champion that. If we do that, we would be on our way to be to make a real excellent and strong contribution to strengthening health systems in Uganda. So in brief, let's go back to our strategic plan of 2018 for the Nursing Now campaign. Let's implement it fully. 2, let's take advantage of the new commissioner, the new federation, and let's move together, united, well-disciplined. There is also the issue of strengthening the council. There are things there which need to be sorted out. But again, the commissioner is here. We should support her through this federation. We identify what our challenges are, what the solutions are, and then we use all those places on the tables which we have to put those weaknesses right. So the opportunity is there. Let's take full advantage of it. And I would like by June next year, we should have had, we were supposed to meet quarterly, but I don't think those quarterly meetings are taking place. It seems to me the office of Catherine Odeke is not supported in one way or another. So how can we do that so that the strategic plan is implemented fully? We have the opportunity of Dr. Musene, the one who just spoke before me, being the head of Midwife. Again, there, we should make sure that the gaps in training are addressed. I think we are in a strong position. We have an excellent strategic plan, and we have the support of the government, the PS, the minister, they all support us. And of course, other champions. I believe I'm one of the champions for nursing. I have a big story which I can tell another day, but some of you know, which made me a strong champion of nursing. So let's go, let's go, let's go. Everything is set to go. Thank you.
Thank you, Professor. We really enjoyed your presentation there. And I don't know if you're aware, as soon as we released the poster for this event, one of your former patients said on social media that you'd actually saved their life and, you know, wanted everybody to know. So we really applaud you for everything you're doing and breaking down barriers between doctors and nurses and working synergistically. So thank you so much, sir. So next we're coming on to our keynote address part 2. This is with our guest speaker from the USA, Dr. Thomas Serena. Now, Dr. Thomas Serena is a surgeon and is an expert in advanced management of infections in wounds, and he's going to speak to us more about that. And then after, we will enjoy a Q&A session with him, which will be moderated by Mr. Edson Monday. So, sir, handing over to you. So we're just waiting for Dr. Serena to join us. So I just wondered if Professor Omaswa might stay on for a little bit of a Q&A, because I'm sure we do have some questions about his excellent presentation. So if you wouldn't mind, sir, we'd like to take some questions.
I'm available.
Thank you, sir.
Yeah, good morning, everyone. I've been fortunate from Barara University, a lecturer in the Department of Nursing. I have some submission to the previous speaker before Professor Omasoha. Am I allowed to ask? Or submit my...
Yes, please ask. Thank you very much.
I wish to appreciate the concept of practitioner nursing as an advanced in, which is good. And she has mentioned that someone has to have masters in a certain recognized field of care as a specialty, which is really very good. I didn't know that in Uganda we have nurse practitioners, and if they are there, how are they empowered to diagnose, to also make subscriptions independently? I understand you mentioned that they can also consult and work with other interdisciplinary professionals, which is okay. But I didn't know that we have it already established in Uganda. And if so, when we are guided by our Nursing Act, which was formulated in 1996, how do we get a mandate that this nurse can really ably do such activity independently, given a situation that we are still operating with our Nursing Act, which was formulated in 1996? Again, I have maybe communication from us. We designed our curriculum, and there is a gap in training. As Professor Maso has said, we are lacking leadership, substantive leadership, and we also look at mental health, which really we need nurses in psychiatry. We designed, because we foresaw and we designed our curriculum, but it has taken some time. I hope it is going to be clear. So we looked at that, we saw a gap, and we designed a curriculum. We want to have masters in psychiatry for nurses, and also masters in management and leadership as a position. Thank you.
Thank you very much. So, Professor, could we hand back over to you to respond to the question, please, sir?
Okay, the question of advanced practitioners, I think Dr. Musene is the more qualified to answer that, because as far as I know, we do not have the legal instruments for that in Uganda today. However, I know that since time immemorial, as I grew up in colonial Uganda, nurses were prescribing, where the rural clinic where I used to go for my medical care as a boy, there were nurses there who were examining and prescribing and so on. But the law does not permit it as far as I know of today. So if it is something we desire, we decide to introduce, it will take some negotiation.
And we will forward that particular question to the Commissioner to get some more information on that and come back to you. Thank you very much.
I also see in the chat here, there are some questions they're asking about top management in the Ministry of Health. What I would like to say is that the Minister and Dr. Acheng, Minister is Dr. Acheng, the Permanent Secretary is Dr. Twine, and also the Director General. They are in full support of nursing and the Nursing Now campaign. I know that very well. And they have been working hard. I've been working hard together with them to get the Federation of Nurses reconstituted as a legal body so that it is actually the professional association that is responsible for all issues concerned with nursing in the country. It is the profession who leads, and it's the profession who negotiates. And today we don't have that structure functioning in Uganda, and it's a big problem. So the minister is waiting for us to tell her to come and launch that federation. It is, the legal bits are just about to be finalized. So I want to assure you all that the top management in the Ministry of Health is in full support, and they have moved also to get the commission appointed, because it is they who are responsible to work with the Health Services Commission to have that happen. So the ball is really on the hands of we nurses now.
Thank you, sir. And I think we will be hearing from Dr. Atwine later, who is the patron of the Nursing Now campaign for Uganda. So we're really looking forward to that.
Morning, everyone. Thank you for the presentation. I am called Grace Nangozi from Bara University of Science and Technology. I have two advantages of nursing. First of all, I want to thank for that good presentation. You mentioned that for nurses to move forward, we need proper qualification and competency. So I think that is really good. So I believe that with the Nursing Now campaign, we need to see how we are going to emphasize that so that we move. And I want also to re-echo that oftentimes nurses find themselves in leadership roles by appointment without the qualification aspect. For example, you find somebody has been appointed ward in charge. As an in charge, you require the leadership skills to be able to really execute your duties as a leader. There are very many small things that our nurses are missing out to make them better nurses. So I think, Catherine, we really need to take this on board, and we design short courses for our nurses who find themselves in leadership role, and yet they do not actually have the qualification. I think that is going to make us really move forward, because they should be able to navigate between hospital administrators, the ministry, fellow nurses, other healthcare professionals, and that's where there is a big gap. Then Professor also mentioned that he's not worried about the queues taking over the jobs of nurses. Professor, there is need to worry. Why? Because we are training enrolled nurses who are supposed to be enrolled comprehensive nurses, supposed to be in the community. And yet, these nurses are not given opportunity to work in the community. Now we want to create another category, thinking they will make miracles in the community. How, Professor? This will bring about confusion in the healthcare delivery. You imagine a senior 4 handling a pregnant mother, for example. What experience is there? Probably the enrolled comprehensive midwife or nurse may know some technical things that require the service delivery. And lastly, on the point of advanced nursing practice, yes, in Uganda, nurses and midwives have been prescribing, especially midwives. But now when we talk of advanced nurse practitioner, then this is a specialty that has got to be recognized at an international level with the proper process of training, and we should have a curriculum. Indeed, we need to develop a curriculum so that these people are standing out as specialized nurses in this area, not just prescribing, paracetamol and what. No, it is a specialty. So I think this is an area we need to embrace, and this is an area that is going to bridge the gap between community and healthcare facilities. If these people are based in the community, surely nurse practitioners in other countries have done a good job in enhancing the healthcare deliveries. But they need to be well empowered that they are able to not only prescribe, but to interpret laboratory results and even x-rays. And their pharmacology must be very strong so that when they make a decision, they really make it to the betterness of that patient. And when they refer or when they consult, they are speaking at the same language. I submit. Thank you.
Can I respond to that?
Yes, sir, certainly. Please do.
Colleague, I didn't get your name, but that's a very brilliant submission that you have made, the discussion points you have raised. First, let's go back to the question of community health systems and those village health teams and the nurses. I have no problem with the enrolled nurses being community health workers who are managing the village health register, making sure that everyone in the community, in every household is accounted for. The Ugandan health system has got that structure. It's excellent. But it was supposed to be led by a village health team of 9 people, one of whom is a community health worker selected by the community. And then they are linked to health center 2, where those enrolled nurses are, and they report to those nurses. So there is a place for the enrolled nurse at health center 2 or 3 to relate to these village health teams. And your concern, I think, will be addressed by that. But I'm also reading in the post here, Catherine Odeke says, abolish enrolled nurses and midwives. I have a problem with that too. I think that's wrong. If you abolish enrolled nurses and enrolled midwives, you will have then that gap down there has to be filled by someone. Nursing services are needed there. So this issue of saying all nurses must be diploma and graduates, I think is misplaced here in Africa. If other people are doing it, let them do it, but let's not import things which are not going to help us. So I agree completely. Then your other point, which I liked very much, is equipping leaders with leadership competencies. Absolutely, absolutely. So all nurses, either as part of basic training, should have leadership in it, but then there should be a program for those who get to take up leadership position. Like, for example, Beatrice Amuge now, she needs to have short courses on people management, short courses on planning, short courses on what. When I became the government chief surgeon along the way, I left I didn't leave, I was still a cardiac surgeon at the same time. I had now to take special courses in total quality management. I took courses in corporate governance. I took many courses which enabled me later on to become Director General and so on and so on. So let's do that. And who is going to organize that? That again is the job between Beatrice Amuge and Dr. Musene. That's something we should start to do as part of our strategic plan. So the conversation is going well, but we need leaders to make sure that all these things we are talking about actually happen. And those leaders we already have.
Thank you very much, sir. Do we have any other questions from anyone else? Let me just see. Right, so we're going to come back to you if there are any more questions. Thank you very much.
There is a question in Lira. Mr. Matthew Pearson, can you hear us from Lira?
Yes, I can hear you, Lyra.
Lyra's on, yeah. Lyra's on. Right.
Thank you very much for the program. I'm called John Opio. I'm not nurse here at Lira and the hospital. My only question is that how can the nurses, for example, the enrolled nurses and the midwives from the local remote community in Uganda, especially in Karamoja region, how can they be empowered in leadership skills, given the fact that the institutions are not so close? How can they be equipped with these leadership skills? We are really having that challenge. That is where I came from, the regional referral setting. So how can we be helped to uplift those standards of education, especially with leadership skills, to keep them in the community, in the management field? Thank you.
Did we not answer that question before? It is similar to the other one, isn't it? So I don't know. Maybe they didn't hear. But the point is that our leaders should now make sure that leadership training is there in pre-service curricula, that is Dr. Musene, and then two, those nurse leaders who emerge and are going up in management positions, there should be a management training provided for them as in service, and that is Dr. That's Beatrice Amugi.
I tried to, but he'd already jumped in.
So you are right, that is needed. I see also postings by Catherine Odeke that Sudan and Kenya have abolished enrolled nurses. Please don't follow them. They have made a mistake. They will regret it.
Thank you very much, sir. So we're now going to move on to our next session. So this is going to be moderated by Ms. Primrose Magala. So we are going to be looking at developing our global young nursing and midwifery leaders, and that is with Dr. Catherine Hanaway, Global Health Consultant UK. So I'm going to hand over now to Dr. Hanaway. Thank you very much.
Thank you very much for that introduction, Matthew. So esteemed guests and speakers, conference organisers, Elizabeth Pearson and her team, and all of those who are participating, thank you so much for inviting us this morning to join you and to speak about some of the work we have been involved with. If you could all switch off your microphones if you're not speaking in the session, and that will help us as we go through our presentation. So hello, my name is Catherine Hanaway. I know that many of you I have met either in Uganda or on travels globally. I was in Kampala to launch Nursing Now Uganda with some of the great leaders of the campaign, Lord Nigel Crisp and Professor Francis Amaswa, who we've just heard from there, as well as many of you too, Sister Catherine, and now your new Commissioner, Mrs. Beatrice. So it has been my pleasure to have been working with you all in Uganda for some time. Today, I want to speak about developing young nurses and midwives in particular. But thank you to Professor Amazwa for the points he has raised, which are really pertinent to the development of your healthcare system, developing leaders at every level, and also, actually putting into practice your strategic plan for nursing now, not just having it sitting on your shelves. I am delighted to hear about the creation of the new and stronger Nurses Federation in Uganda. I think that will be a really important move. And we heard a lot in the last session about development, professional development, and in particular about continual professional development and how you can strengthen that in Uganda for nurses and midwives. You will hear later, there is a short session by the World Continuing Education Authority, Craig Fitzpatrick, WCEA, about how he is helping all countries in Africa to strengthen CPD. So do listen into that session and see how you can all become involved and find some of that training that you are so eagerly seeking. So today I'm going to be presenting with a team and I will be introducing them as we go. I want to share my presentation with you now, so I'm just making sure that I can do that. Can we enable me to be able to share the presentation that I have, please?
Yes, Dr. Catherine, you're the co-host. You can go ahead and share the screen.
Okay, thank you. So this morning, we're going to be talking about the 2020 Nightingale Challenge, and we're going to be using that as a case study from Northern Ireland, where I am working with a group of young nurses, and how it links with Uganda and all around the world. We're going to talk about the importance of inspiring, of role modelling, of mentoring our young nursing and midwifery leaders, to enable them and empower them to become agents for healthcare change. And we're going to talk about making those links both globally and locally for young nurses, and looking what the future opportunities are for young nurses and midwives in Uganda. So here is the team who are with me for the presentation today, and they will come in a little later on. They're here to tell you their story, their leadership journey story, and what it is like being part of a network, the Nightingale Challenge. We have Michelle, who is there, and I can see her on the screen too. Michelle McCullum is a public health nurse based in the Belfast Health and Social Care Trust in Northern Ireland, and she is a participant on the Nightingale Challenge programme in Northern Ireland. Many of you will know Penny Wampamba, and I can see Penny there too. Penny is living and working in England, and she is a diaspora from Uganda, and she works as a neonatal intensive care nurse. And she has been very involved with many of the initiatives that we have been doing with the Nightingale Challenge, and she will tell you her story. We also have Rashid Salim, who is from Kenya. And again, Rashid is one of our associates as part of the Nightingale Challenge, and he will also tell you his journey, but some of the work that young nurses in Uganda will be able to be involved in as part of the Nightingale Challenge programme, but an initiative he is leading for the Africa countries. So we know there is much that nurses and midwives can do to help strengthen nursing and midwifery to enable us to improve health globally. the initiatives and the things that we have heard about already this morning need to be put in place and carried out across Uganda and the world. They were described in the report on nursing and midwifery. How were we to achieve universal health coverage? And these are the things that we need to be focusing on. We know that the Sustainable Development Goals will not be achieved without nursing at the heart of those 17 areas that we must continue to focus on. But we also know, particularly for young nurses and midwives, this is like a Rubik cube. When one thing moves, everything else shifts. And we need to develop our next generation of leaders to be able to help us to take this forward. So it is Elizabeth Ero, our chief nurse at the World Health Organization, who said, invest in leadership potential of the next generation of nurses and midwives, and they will change the world. So we are here now. The Nightingale Challenge was launched back last year. And it was asking everybody, every health employer all around the world to provide some leadership development and training for young nurses during 2020. The aim was to create a global. Everybody switch off their microphones, it will help the sound, please. To create a global movement that will equip and empower that next generation to take this forward, working alongside our senior and experienced nurses and midwives too. So in Uganda, you accepted the Nightingale Challenge. Last year, you talked about how you would take this forward as part of your Nursing Now campaign. And indeed, you registered a number of initiatives on the Nursing Now website. There are 4 of them listed there, and we can see from the pictures that Winnie has sent me about how Sister Beatrice and Sister Catherine Odeke and all of the rest of your senior team started to put this in action before the pandemic broke out. And you had a number of initiatives already underway. 45 nurses were trained in leadership and management skills. Some nurses were trained in research and how to apply research. And this will pick up once the situation allows it in Uganda. But you are certainly very much part of the initiative there. But still there is room for every organisation, every hospital, every university in Uganda to pick this up and decide what do we need to do to upskill our new future leaders in leadership, in management, in policy and decision making, how to have impact, how to be an advocate, and so on. There is much material there that is available. And again, this takes us back to the importance of CPD and how you find that good and reliable material. So I want to use Northern Ireland as a case study. I've put a picture up there of the United Kingdom so you can see where Northern Ireland is. On the island of Ireland, to the north of it, you will see an area, Northern Ireland. Northern Ireland is divided into 5 for its hospital and health and social care trusts. Every one of those trusts launched its own Nursing Now campaign through the Nightingale Challenge. And so every one of them agreed to put on a programme for their nurses, which was fantastic. And I'm sure a coordinated effort like that across Uganda, albeit a much bigger country, a much bigger place, can still happen. So every one of those areas, every one of those trusts is running a programme and sharing what it is doing. Alongside that, 30 nurses were appointed to go on a global leadership programme. And here they are in the picture, and I have one of them on the presentation with me today, Michelle. But in the top corners you will also see there is the chief nurse for Northern Ireland, and there is the lead nurse for public health for Northern Ireland. It is essential that you have the support and the commitment of those very senior people when you are trying to do this. It is also important to have the commitment of people other than nursing and other than nurses and midwives alongside. So it's a wonderful programme. I am the programme director for that programme for those 30 very fortunate young people. It has workshops, and we talked about some of the things that it includes: leadership, policy making, advocacy, team working. It has personal development tools. There is some one-to-one personal coaching for the people on the programme, and they are all being mentored by a senior leader. That is really important, that you take on that responsibility of helping, holding hands with those people who are coming behind you as the leaders of the future. There are e-learning modules in quality improvement, and everybody has to undertake a module in quality improvement. There was an opportunity for international travel as part of this programme. Of course, at the moment that is on hold. We had hoped to bring some of those young nurses to Kampala for this conference, but instead we are linking in other ways. We set up a Facebook page, and everybody is welcome to join that, every young nurse and midwife, called the Nightingale Challenge Northern Ireland Goes Global. And we are networking now and peer buddying with some international young nurses called our Global Associates. And here they are. We have about 25 global associates now from all around the world. Many of them are from African countries. They are young people who have shown an initiative and an interest in global health, and that we have seen to be doing some very innovative, very thoughtful global things, and just already showing their potential. It is an absolute delight to be working with these young people alongside Northern Ireland. As part of that programme, you will see we have 4 young nurses, Sarah, Harriet, Winnie and Penny, who all are associated or from Uganda. And it is wonderful that they are represented and representing your country. They link in by all sorts of innovative ways. I'm going to pass over now to our first Nightingale Challenge nurse to join me in the presentation, Michelle.
Thank you, Catherine. Hello, everyone, and greetings from Northern Ireland. Thank you for the opportunity to speak today. My name is Michelle McCollum, and I am a public health nurse in the Belfast Health and Social Care Trust. I work with the Health Visiting Service in the community, caring for children aged 0 to 4 years old. My role involves administering the United Kingdom Childhood Immunisation Schedule, as well as visiting children in their homes for developmental reviews. Shortly after starting this post last September, I was nominated by my team lead, Debbie Sterrett, for the Nightingale Challenge Global Leadership Development Programme of Northern Ireland, directed by Dr. Catherine Hanaway and a steering group of senior nurses and midwives, mostly from our Department of Health, who commissioned the programme, including Mary Frances McManus and our Chief Nursing Officer, Charlotte McCardle, who has been a great role model for me in nursing leadership. You can see her in the bottom right corner of the photo they're presenting to us at one workshop. It has been such an encouragement to see how these senior nurses and midwives have invested in our learning and development, and to know their dedication to the 30 young nurses and midwives in the programme. Not only are they providing opportunities for growth and development into the future, but they have also encouraged us that we can be nurse leaders from our current position. It doesn't matter our role, pay or age. As young nurses, we can create positive change in healthcare. One way we've been able to make improvement is by carrying out a quality improvement project in our own area of work, which has been an eye-opening experience for me, as something which initially seemed quite overwhelming, with the right support and direction has been very achievable, and I felt empowered to make positive change both now and into the future by recognising that even a small idea can create a real change. And to help us with this, we've been able to complete 4 online modules from the Institute for Healthcare Improvement, which has been a great help in developing our knowledge and skills. We have also been encouraged to set up a mentoring contract with a more senior nurse leader, and I have found this very beneficial with my mentor, Ruth Hamill. It's so helpful to have someone to go to with ideas and to support me in any challenges I face, an ear to listen and a steer in the right direction. We have had multiple face-to-face and virtual workshops with senior healthcare leaders, both local and global, which have been educational and inspiring. And at each workshop, we've also been able to link in with global nurses. And we've set up partnership with these 20 global associates, 2 of whom are Penny and Rashid, who will speak shortly, which is a fantastic experience, sharing our stories and learning from each other, especially being a support through the recent global pandemic. This partnership has showed me that nurses across the world experience many similar challenges, and we can learn from one another. One global nurse I've partnered with is Winnie Nakamanya from Uganda, who presented yesterday on eye health in the community. It has been lovely to get to know Winnie and her nursing journey, to share our stories and learn from one another, and we have benefited from each other's support during the Nightingale Challenge and global pandemic. I met Winnie in March when we had the opportunity to go on a learning visit. We were able to go to London in England in the United Kingdom, along with 3 other participants from the Northern Ireland programme, where we had an informative afternoon with Lord Nigel Crisp, co-chair of the Nursing Now campaign, and visits to the Royal College of Nursing and the Florence Nightingale Museum. But the main event of our trip was the 2-day Commonwealth Nurses and Midwives Conference, where the top 2 photos are taken. It was such a great opportunity to meet and learn from senior healthcare professionals, and I would encourage any young nurse or midwife to attend such a conference. Sadly, we did note an absence of young nurses and midwives, which I felt was a missed opportunity, as they are the ones such an event should be inspiring and encouraging. So please do invest in your young nurses and midwives. It's so important to help us feel valued, supported and empowered in our nursing and leadership journey, and I hope I have shown you that. So in finishing, I would like to say thank you to everyone who has contributed to and enabled me to participate in this programme. Thank you for the time and resources invested into my leadership development, not only now where I am today, but also into the future. Thank you very much. I would like to hand over to Penny Wambamba now.
Good morning, everybody. My name is Penina Wampamba. I am a neonatal intensive care nurse. I work in Manchester, but I'm also a Northern Ireland Nightingale Global Associate. And today, thank you, Catherine, I've been called to present about my journey on becoming a global health nurse. I started maybe 2 years ago, and I met Catherine and I met Elizabeth, and at this point I was actually a student nurse. I was in my final year of nursing, and this was my first introduction to global health nursing. I didn't actually know that this existed, and it was incredible because I was able to meet so many different people who want to just essentially make the world a better place, and actually raise the profile of nurses. And so this year I was invited by Catherine to actually join the Nightingale Northern Ireland Challenge. I travelled to Northern Ireland where I met Michelle, and I met so many different nurses who are in leadership roles, and I met Catherine McArdle, their chief nurse officer, and my eyes were open to all these different people and who share the same vision. And this is something that would have never happened if I had never met these people. And as someone that's starting out, I didn't know how to navigate this whole, I didn't know how to navigate becoming a global healthcare nurse, a global nurse. And through this, I've been able to see that I need to get more, I need to learn more, I need to understand the different healthcare systems that exist around the world and how these work, and also how we as young nurses can also add and contribute to making these healthcare systems much better. And as a young nurse, my goal is to become a leader of some kind. And being on this, being on the Nightingale Challenge, I've been able to participate in the modules that Michelle mentioned. These Institute for Healthcare Improvement modules, they have taught me, they've pretty much reminded me of things that I already knew. However, it's that greater detail, and it's these things that we don't pay attention to them in our day-to-day nursing. And as someone that's starting out, having this knowledge is very important. It allows me to actually undertake further learning and have a much better understanding of these healthcare systems and how we can actually improve healthcare. Through this being a global healthcare associate, health associate, I have met people like Rashid, and Rashid recently invited me to talk on a webinar called Young African Nurses for Global Impact. This was incredible. This was just amazing to meet young nurses within Africa, within neighbours really to me, doing great work. They are pushing other young nurses to actually learn about the leadership roles, understand how they can actually get into these leadership roles and the opportunities available to them. And I encourage all the leaders on this webinar today to join the Nightingale Challenge, like Dr. Catherine said, and to just ensure that they uplift other young nurses, they make the environment safe, and they make the environment an environment which these young nurses can actually come and be ready to ask that, oh, are there development opportunities available? How can you aid me? Can you be my mentor? And this is something that I have learned that's very important. And so yeah, I would like to thank Dr. Catherine and the National Healthcare Conference for today. And yes, thank you very much. I hope you have a nice rest of the conference.
Hello, my name is Rashid Salim, and currently I'm a champion of the Nightingale Challenge. I also sit at the ICN, International Council of Nursing, as a member of the Student Steering Committee, where we're looking at, walking the talk in terms of bringing the young nurses on board. So, sorry. Previous slides, please. Yes, sure. So, my journey has been, I started as a young student leader where I believe on servant leadership, and through the networking, and I really thank Dr. Catherine Hanaway for the opportunities to actually showcase the young nurses and just raise the profile of nurses. So I was able to present a paper at the Global Network of Public Health Nursing here in Kenya last year, and it was a great opportunity for me to, present before a global audience and just speak to a few, the who is who in the nursing profession. Next slide, please. Yes, the two photos just show me and a few other young colleagues, and you can see Dr. Catherine Hanoi, where we were facilitating a workshop for young nurses in Qatar in the World Innovation Summit for Health. And it was a very nice exposure where we were looking at the advocacy toolkit, and we were able to actually come up with a young nurses organization. We find that in Qatar, they didn't have a platform for young nurses and students where now we can actually be able to empower them to do great. So the next slide is also I and you can see a few other young nurses where we were talking to Princess Muna during the same conference, and it just shows how great opportunities come up when we come together as young nurses and are empowered to serve better. Next slide, please. This, I want to call upon the young nurses as we speak of coming together and uniting for the global impact. We have the African Novice Nurses and Students Initiative, where we're also launching a leadership program through the Nightingale Challenge, where we're now calling out on all the youth nurses to join in the leadership development program. It's an 8-week program where we're focusing on five topics as we go on. Someone come on. Okay, thank you. So this open and how someone can enroll is we normally share our opportunities on our social media platforms. For the young nurses, look out for ANSI, African Novice Nurses and Students Initiative, through Facebook, through Twitter, and just take advantage of the power of social media to get some of these opportunities. At this juncture, let me just thank Dr. Hanoi for the great opportunities that she is actually doing to raise the profile of nursing by empowering the current generation or the future generation of young nurses and leaders. Thank you so much. I now want to give back the opportunity to Dr. Catherine Hanoi to take it up. Thank you, and I'm really happy to be part of it. Thank you so much.
Thank you very much, Rashid. Thank you to Michelle. Thank you, Penny and Rashid. What wonderful young future and current leaders we have there, and they are absolutely inspiring of our professions. I want to finish now by just reminding us all that leadership is key to taking forward and improving healthcare all around the world. We need leaders at every level, leaders who can communicate, who can persuade, who can take their seat at the table, want to understand policy, want to understand management and research. We need those who are creating new roles, innovative roles, the ones out there in the communities, the specialist roles. But, you know, please, I implore you to really grasp this in Uganda, grasp continuing professional education at every level, and let us really, you know, take the professions forward and take those young people with us on our journey. Thank you for giving us the opportunity to share this work with you, and we look forward to supporting you as you really do celebrate the year of the nurse and the midwife, both in Uganda and everywhere in the world. Thank you.
Thank you so much, Dr. Catherine, and all our wonderful young nursing midwives. It's fantastic examples of what can happen if we support the young generation. Does anybody have a comment from the audience, please? Okay, we have somebody with their hand raised. If you can unmute yourself and speak, please. We've only got your email identification, so please give us your name, ask your question.
I'm Sister Kuranto Namsofi, Rubaga Hospital. I really appreciate the presentation from Catherine. And this has been very good to us as you presented the young midwives and nurses. The leadership which you have talked about is very useful for us, and we would like to know whether there is any plan you can make to put up a course of training leadership of young nurses and midwives.
Would you like me to answer that question, Primrose?
Would it be very nice to put up such courses or trainings for leadership for young nurses and midwives? Not these advanced courses of masters or management, but just this kind of courses, however small they may be. I think they can help us a lot for our young nurses and midwives.
Yes, please, Dr. Catherine, please answer the question. Thank you so much.
Thank you, and a really good question to be asking. There are some programs already running in those organizations that I showed earlier, and we know that they have already provided some training. Now, I think one of the things I see in Uganda is this need for really evidence-based, comprehensive, accessible learning, and some modules that could be delivered face-to-face or partly online. And the drive for encouraging CPD at every level, how can you access this? And we have been working closely with the council in Uganda and many of you on this call. And I hope that perhaps champions like Professor Francis Amaswa, along with Sister Catherine and Sister Beatrice, can help to drive forward the need for comprehensive evidence-based CPD. Now, as I say, you will hear more from the partner of the ICN, WCEA, World Continuing Education Authority, later, and he will show you there an example of how you can access this free online training and how you could take some of those modules and deliver them yourselves in a classroom as well as using online tools. And I think this is something that is absolutely crucial for you all. And there will be modules on there about leadership, or you can develop your own and have them put onto that platform so that you can all get certificates, you can all have the same sound, free education to get you into the positions you need to be as leaders.
Thank you very much.
Thank you so much, Dr. Catherine. Any other comments, please? There's a hand
I have
raised.
a comment that I would like to, hello?
Okay, please go ahead. Thank you.
Good day, everybody. My name is Dr. Skola Matovu from the US, California. And I just wanted to take this opportunity to thank you all for your presentation and for the organizers as well for this amazing and very insightful sessions that we're having. To Dr. Hanaway, I would like to make a comment, and I think to everybody, to say that I think even though we advocate for leadership skill development, professional development skills within the nursing community, I think it would be a missed opportunity if we don't highlight the fact that as a nursing career, the nursing profession, nurses are leaders by virtue of our profession. And besides the development, besides the skills in leadership and how to manage and how to lead initiatives, as per our profession, we are leaders. The ability to come up with nursing care plans, the ability to educate our patients, the ability to, inspire others, both patients and their families, and work interprofessionally, I think those are inherently leadership abilities. And so I think, yes, we can encourage the leadership development skills, but I think we have to highlight the importance and the fact that actually nurses are leaders by virtue of having that degree or that qualification. So I just wanted to make that comment. Thank you for the opportunity.
Thank you so much, Dr. Matovu. There's another hand raised, Okiria. You've only given your Gmail address. Please go ahead.
Okay, thank you very much. West Peru from Barara Regional Referral Hospital. I'm very grateful for Dr. Catherine for inspiring the young nurses for making a difference. And we are happy because the young nurses, they have new skills and new knowledge that can really empower nursing and midwifery in the future and in the community as well. So I want to thank everyone who really organized this conference, and we are very grateful for the modern, because we can now communicate to the international nurses, which is really very good. Dear Breast, thank you very much for listening.
Thank you so much, sister.
Question from Lira Hospital.
Statement from Lira. Welcome.
My name is Adomo Petwa. I want to thank you so much, Dr. Catherine, but my concern goes as to raise up the young nurses and midwives to the position of knowledge and skill in leadership. I would request that you also engage Catherine Odeke and Beatrice, the commissioner, Beatrice at Muge, into this structuring the levels of nurses in Uganda, because we find a challenge where an enrolled nurse has already upgraded in a diploma, in a bachelor's, and they have not been promoted. Shortly, right now, Catherine is looking at eradicating enrolled nursing, yet they have not streamlined even the structure in the current scheme of payment, but they are adopting other things that have happened in the country. We pray that we enroll it and make a clear structure for the Ugandan nurses as we develop. Thank you so much.
Thank you so much, Lira team. Any other final comment before we move on, please?
Good afternoon. Thank you very much for the wonderful presentation. I'm called Atekiki Manuel. I'm a young graduate midwife, currently working in Imbarara Regional Referral Hospital as a nursing officer. I would like to start by appreciating everyone for the wonderful presentations that have actually encouraged me a lot. And I have a number of recommendations regarding investing in young nurses, in the leadership of young nurses and midwives. In Uganda, when we look at our health care system, we really have a problem, starting with the structuring. We have now so many graduate nurses and midwives. However, most of them have not been given an opportunity to execute their leadership potential. We usually in Uganda here, after your bachelor course, probably midwifery or nursing, we go through what we call internship training, which usually goes for a year. However, in most of the internship centers, these graduate nurses, I must say, I should say, those people who have probably attained their level and have the necessary ability and leadership skills to mentor them and train them. I take an example. I myself, as I was training, my internship training, that limited me a lot. So in Uganda, I think we have to find a way how we also include graduate nurses and midwives into the actual delivery of the health care. And then these graduate nurses and midwives, they can mentor the incoming intern nurses and midwives so that we can actually better them, because some of the skills that they have been trained, these local nurses and midwives don't actually have them, and that limits them, and you find at the end of the day, they have a lot to include. Secondly, we also have a problem in our structuring, as the previous speaker has outlined. You find that especially the direct graduate nurses and midwives, they have no opportunity of entering into either government or private settings. When you go to private settings, they will say, we can't afford to employ you. When you come to government, the government will say, for someone to qualify for your level, you should have trained at a diploma or a certificate level, and you should have the relevant experience. So all the direct who are actually young nurses and midwives have lost opportunity to gain into employment, to gain into health service delivery. So it will actually be hard for them to execute and deliver their leadership potentials, which have been acquired from the different universities. Thank you very much. I remain Athlete Emmanuel, a graduate and very prudent midwife. Thank you.
Thank you so much, everybody. Thank you so much. We shall take all the feedback on board. We now need to kindly move on for the interest of time. Thank you once again. I'll hand over to Matthew, please. Thank you.
Thank you very much, Primrose, and what a fantastic presentation. We'd just like to really thank Dr. Hanaway, and also to Penny and Rashid as well, and Michelle for their contributions. Fantastic to hear from them. And you know, nurse leaders and midwives are being very well supported by Dr. Hanaway. And we just love how sowing all this information to our young people is going to turn them into our next generation of leaders. So we are now moving on. So we're going to move on to poster presentations, and we're going to hear from Namukasa Shamim, Mr. Aliga and his team, and Mr. Musa Sangyang, and that will be moderated by Ms. Primrose Magala and Ms. Winnie Nakamanya. And one more thing, if I can just ask again, if you have an opportunity, we'd love you to post to NHCC Uganda 2020. So we'd love to see your posts, be it on Instagram, Facebook, LinkedIn, Twitter. Well, let's really make this event known and reach out to people. So thank you very much, and handing back to you. Thank you.
Okay, are the presenters ready, please?
Yes, please. This is Shamim Namukasa.
Welcome, Shamim.
Thank you. Should I share my screen?
Yes, please do.
My name is Namukasa Shamim, and I'm a faculty at Aga Khan University. So I would like to appreciate the team for organizing this conference, and I'm very grateful for having been given an opportunity to share my findings at this fraternity. The topic of presentation is about sickle cell disease screening, and I and my colleagues are set out to find the knowledge, attitude, and use of premarital sickle cell disease screening among prime gravida mothers or women at Mulago Hospital. And we very well know that sickle cell disease is a chronic disease, and literature shows it that 1.1% of couples worldwide are at risk of having a hemoglobin disorder, and that 14% of partners actually find out that they are carriers on delivering children who are sicklers. It is also well known that 70% or majority of sickle cell carriers or cases actually found in Africa as a region, and this is expected to increase by 2050. And we know that, of course, Uganda is in sub-Saharan Africa, and the recent survey actually about sickle cell disease that is in 2016 by UDHS showed that the sickle cell trait prevalence in Uganda is at 13.3%. And about 5,000 to 20 babies of sickle cell disease actually die in Uganda in a year, and this is really leading to the high under 5 mortality rate. And also a study by Oku showed that most of the people find out that their carrier state after producing a child who is having sickle cell disease or is a sickler. So several studies that reviewed in our study showed that actually that the people who are likely to screen for sickle cell disease are those who are immature in age, who have been in marriage for some time and are well educated. So we set out to find out whether that is what we would find in the population in Uganda among these prime gravida mothers, of course, who are expecting for the first time in Uganda. So some of the objectives that we hoped to achieve in our study was the knowledge, attitude, and how many mothers actually did screen or for sickle cell disease before marriage. And we also set out to find the factors associated with premarital sickle cell disease screening. So we did a convergent mixed method study, and it was in phases. Phase 1 included a cross-section study where we set out to the antenatal clinic and we collected data among 500 prime gravida mothers, and all those, of course, consented to participate and were mentally able to give consent were included in the study. So we analyzed that the quantitative data using a starter version 12. We did a phase 2, which was a case study design, and we collected qualitative data. We held focus group discussion at antenatal clinic Mulago before it shifted to Kawempe, and we also held some focus group discussion with family or caretakers of children with sickle cell disease at sickle cell clinic, and also interviewed the in charge of the sickle cell clinic. This was to help us better understand whether the people who are actually having children with sickle cell disease really also sort of screening, because some of them actually find out that they are carriers when they deliver the children who are sicklers. So we set out to find out from them whether they also actually thought about screening and what they knew, or whether they knew about premarital sickle cell disease screening. So the results that we found out that quite a big number of actually mothers, these prime gravida women, had good knowledge about premarital sickle cell disease screening. As you can see that about 81% of them had good knowledge. And of course there we had a number of questions, and we allocated, and again at the end of the day categorized the final score, and then we also found out that the attitude was positive. And of course, when we held focus group discussion both at the antenatal clinic and at the sickle cell clinic, we found out that some of our responses were quite interesting. That one of the participants at the sickle cell clinic said that some adults don't know about it, and the age of the mothers being so young today, especially teenage mothers, they don't know and are probably are not concerned, and they're just excited about their new marriage. And when it comes to attitude, we got a comment from a participant at the antenatal clinic, and this prime gravida woman said that, I believe in not worrying about something. If something does not hurt me, then why should I go ahead and try to find out? Because at the end of the day, I may get bad results, and then I start worrying. So you could see that even if that attitude quantitatively was quite good, but some of the findings qualitatively were showing that people are not really that interested in finding out their status. So when we talked to the key informant, and that was the in charge at the sickle cell clinic, you realize that she, of course, as she was interacting with some of the family members with sickle cell disease, she talked about how, you know, some of these caretakers or mothers or parents expressing their frustration about the lack of knowledge and the importance about sickle cell disease screening. And they felt that the healthcare providers, they should be providing this information to them regardless of whether or not the patient asked about sickle cell disease screening, because some of them actually found out that they are carriers after giving birth to children who are sicklers. So when we have tried to analyze data in regards to how many prime gravida mothers actually had screened for sickle cell disease, and when we talk of the screening, this was self-reported, and at the end of the day, we probed further to confirm whether this was true or not. Its result showed that only 11% reported having screened for sickle cell disease screening. So now we went ahead to again further analyze this data and find out what could be some of the reasons that motivated these people to actually screen for sickle cell disease screening. And we found out that, you know, having a history of family sickle cell disease, having a positive attitude, and knowing their partner's sickle cell status actually encourage them to first find out about their sickle cell status. So all in all, we are saying that even if, you know, we found out that mothers or these prime gravida women had positive attitude and good knowledge about sickle cell disease screening, we know that these are not enough to actually encourage someone to still uptake a screening services. So we are recommending that, you know what, there is continuous or a package designed to keep on telling us about, you know, reminding us about our duties, about screening for sickle cell disease screening. And we know that screening actually is at a cost. It is not free of charge. So at the end of the day, and by the time we conducted this study, there were so many challenges still at the sickle cell clinic. Of course, they have been resolved. And the cost of screening for sickle cell is at a cost which majority of the population may not be able to afford. So of course, we are looking, we recommended that the policymakers should make some of these services available either free or at a cost which is relatively affordable by the communities. So, and of course, we would like to thank the staff at the sickle cell clinic and the antenatal clinic of Mulago Hospital for giving us that opportunity to work with them, and of course, the people who participated in that study. Thank you very much.
Thank you so much, Shamim, for raising awareness and helping us to understand the critical challenges regarding this subject. It goes to show why nurses and midwives' roles are very important in the preventative and health promotion aspects. So I'm now going to hand over to my co-moderator, Winnie, to introduce the next presenter. Thank you.
Okay, who's the next presenter? Yes, hello everyone. The next presenter is Mr. Cliff Aliga. Please go on with your presentation.
Good afternoon, everyone, and thank you for this opportunity to have this online presentation. I need to share my screen. Once again, thank you for this opportunity, and allow me to share my study that I conducted with one of my colleagues, who is a clinical laboratory technologist. And this study was mainly about screening patients for the risk of developing sepsis using a tool referred to as QSOFA, and evaluating their blood samples for evidence of sepsis using procalcitonin biomarker. First of all, sepsis is a very serious global problem, and it is characterized by dysregulated response to infection from the host body, and with its mortality rates ranging from really huge numbers globally, about 19 million cases per year, and causing about 5.3 million deaths every year. And when a person gets infection with sepsis, during infection, the body normally releases biomarkers, and one of these biomarkers is what we measured in this study, particularly procalcitonin. And you could be aware that sepsis can be diagnosed using different methods. And one of the common methods in Uganda, for example, is taking a blood culture and analyzing, determining if there's any bacterial growth. And sometimes only doing a CBC to find if there's any evidence of infection. But this particular study used a system or a tool called QSOFA, and QSOFA is simply standing for an abbreviation that refers to a quick sequential organ failure assessment, simply meaning that if the person has infection, the vital organs are likely to fail. And there are studies that have indicated that there are some 3 parameters. When you measure them, it actually indicates a high suspicion of sepsis. So we chose to use this particular tool called QSOFA. And the advantage of this particular tool is because it doesn't use laboratory tests. It simply uses clinical symptoms. And we actually use these clinical symptoms, and in addition to that, we also use what we call modified early warning scores. Modified early warning scores are some clinical symptoms together with some laboratory investigation that actually trigger a high suspicion for a severe infection like sepsis. So the use of clinical assessment guideline for sepsis can actually, QSOFA can generally improve a diagnosis for sepsis. So this study particularly set out to identify patients who are at risk of developing sepsis using this particular tool. And the parameters that we identified in these patients was mainly the 3 key symptoms of respiratory rate, any patient with a respiratory rate above 22, and any patient with the systolic blood pressure less than 100 millimeters of mercury, and any person who has altered level of conscience. And we set out to have basically 3 objectives. One of them was to establish if QSOFA criteria can actually identify patients at risk. And then the second objective was to evaluate the blood sample of this person who we can actually clinically identify and look for the evidence of sepsis in them using the procalcitonin test and using a CBC as a control in this particular study. And then we also thought to predict the risk for sepsis among the study group. So we prospectively did this study. It was a prospective quantitative study design, which involved the application of QSOFA and the MEOS, modified early warning scores. And we trained nurses on how to use these tools, on how to administer it in a routine screening. And our study population mainly was the patients who are admitted in 2 of the hospitals that we targeted in this study. And these patients, when we targeted them, the nurses did their routine work. And as they're doing their routine work, we only selected 2 days in a week to concurrently collect this data. That was Monday and Wednesday for a period of 3 months, which was in 2019. And this was mainly emergency department wards, surgical ward, medical ward, pediatric, and we excluded some wards like maternity in this case, where we did not want to involve that. And then once these nurses measured the parameters of respiratory rate, blood pressure, and altered mental status, if any of these 3 parameters were present, then they will take a blood sample. And these blood samples were sent to the laboratory for analysis. And mainly within a period of 4 hours, the blood samples were analyzed for CBC. And in CBC, we're particularly looking for evidence of infection. And then the plasma was frozen to about 8 degrees, and then they were analyzed for procalcitonin. Evidence of procalcitonin biomarker was tested. And the results actually about this study is kind of the point that we need to talk about right now. In this period of about 3 months, we were able to identify about 72 patients who met the criteria for the patients to be, screened for this study. And the majority of these patients were male. 42 of them were male out of the 72, and the 29 of them were female. And there was no statistical difference between, of course, the parameters that we tested. There was no difference between their age and the gender. However, one of the factors that we found was that being above 55 years was highly associated with bacterial sepsis. And the study also estimated having HIV, high platelet counts, lymphocytosis, neutropenia, and very low or very high white blood cell count were predictive of high procalcitonin level among the persons whom we really identified. And if you look at how we interpreted our samples, for example, I will just zoom a bit, this slide, this particular one. When we interpreted the samples, we use this model of how to interpret because we use a particular machine which recommends that if you find procalcitonin level less than 5, the interpretation is the person has a local bacterial infection. And if you had procalcitonin level ranging between 0.5 to 2 or less than 2, the interpretation was that there's infection, any infection is possible. And when we also, the interpretation also says that when the procalcitonin level was between 2 to less than 10, it simply meant that there's infection, which is likely to be sepsis unless otherwise it is known. But for those persons whose procalcitonin level was greater than 10, it simply meant that these persons had severe bacterial sepsis or they already had septic shock. And if you look at this lower chart, the distribution of the persons with its Q-SOFA criteria, we found in this population that 34 persons had a very high respiratory rate greater than 22. And the 27 of them had altered mental level of consciousness. And the 17 of them had systolic blood pressure less than, actually, that's a mistake, it's less than 100, not greater than less than 100. And when you interpreted this in terms of the distribution of these persons, and then it simply meant that these 34 persons had a local bacterial infection, and the 14 of them had possible infection, and 11 of them out of the 72 had sepsis, which was likely, and the 13 actually had severe bacterial sepsis or septic shock. So this particular interpretation actually met one of the objectives, that whether this particular criteria could really help nurses to quickly identify patients who are at risk of developing sepsis. Now, in our discussion, actually, we said that this study, of course, is in line with what Singer found, that 24% of infected persons with 2 or 3 Q-SOFA accounted for about 70% of death. And that's where our main worry is, that if you are able to identify persons who are at risk, potentially their chance of dying is about 70% of them will actually die if you do not do anything. And this particular study group of ours has a similar risk for the high mortality, where there is a scarcity of ICU beds, particularly when you get in a person who is severely ill, it needs to go to ICU, and unfortunately we don't have enough ICU beds. And this result actually indicate that any person should you find with a respiratory rate between 21 to 24, or breathing hard, and a heart rate of more than 130, or if the person had a new arrhythmia for those facilities which can measure the rhythms, statistically shows that these persons have a very high mortality, or they are moderately very ill. And in this particular study, we found that 18% had a higher risk for a bad outcome due to sepsis. And the sepsis potential, of course, remained a threatening, a life-threatening condition, which definitely causes mortality. And we looked at this study with the recommendations from the developers of Q-SOFA, where they say that the risk of a bad outcome is 7% for every hour delay in administering antibiotics if sepsis is suspected. Meaning that if we use this particular Q-SOFA and we identify the persons and then who are at risk, then it means we must immediately start antibiotics. If we don't administer antibiotics every hour, their risk of dying is about 7% every hour of any delay in administering antibiotics. And in our conclusion, we actually said that this screening using Q-SOFA is a very simple tool, easy to use, and they can easily identify persons at risk of developing sepsis. And it can actually predict mortality of persons. And therefore, we thought that procalcitonin, having a very high predictive value to identify persons with bacterial infection or sepsis, can actually be a very good tool that can be used at a very minimal cost, because this particular tool we use can actually, the test can be done on bedsides, And the QSOFA parameters are very easy to implement. And therefore, in our recommendation, we thought that if all nurses in this country could be trained on how to use QSOFA for screening and identifying persons at risk, will go a long way in reducing the huge mortality that is being caused by sepsis. And adopting sepsis, QSOFA, as a routine tool for use by nurses and the midwife in a clinical setting could be highly recommended, because it is a tool that can simply give a high suspicion of persons who have a very high mortality, and yet it does not require you to do a very rigorous laboratory investigation, which sometimes takes about over 72 hours, particularly blood culture, and sometimes even CBC, the reagents for these machines may not even be absent. And this will go a long way reducing the mortalities of patients who die because of sepsis. So that is simply what this study sought to find out. And thank you very much for listening. And these are my references. And of course, my affiliation is I'm a senior faculty at Aga Khan University. And I'm also a member of African Sepsis Alliance and the president for Critical Care Nursing Association and the African Federation for Critical Care. And I'm humbly acknowledging that this study was supported by some organizations, including Bodytech, and some organization from Uganda, which is called Midlink. And thank you very much for listening.
All right. Thank you so much, Mr. Kalifaliga. Now, for any questions, please post them in the chat box, or you can raise them up as we wait for the next presenter, Musa Sanyang. Next presenter.
Okay, so what we'd like to do is take some comments and questions now, and then we're going to jump back into one of our previous sessions while the other presenter prepares. So if anyone has any questions, now would be a good time to ask them. Thank you. And just a reminder while we wait for some questions, any posts you'd like to make on social media, it's NHCC Uganda 2020. And thank you for those great presentations. I learned a lot there, and I'm sure all of the people participating did as well. So thank you to our great presenters.
Any questions, please?
Yes, I have a comment, not a question, but a comment.
You're welcome.
Yes, I'm being a dental hygienist and seeing a lot of patients with infections in the gums and sometimes in the tooth root. This is one of the ways whereby bacteria can, penetrate into the bloodstream, and that can trigger a lot of infections, which can also lead to this kind of sepsis kind of infection. So looking after our mouth is very important. Otherwise, it's one of the gateways where microorganisms can penetrate and cause infections into the system. And there's a lot of studies now linking a lot of like diabetic and high blood pressure, linked with the mouth. So we shouldn't forget the mouth as we are discussing these health matters, because mouth is really a very important part of the body. So this is the time whereby we can put the mouth back to the body. To the body. That's my little input. Thank you.
You're welcome. Thank you too. Okay, thank you so much. Any question? As wait for the next presenter. That's Musa Sanyang. Musa. If no questions,
respond to some of the questions that are written there.
Certainly, yes.
Okay, thank you. I have two questions. Perhaps others are still probably coming. One of the questions is from Kamugisa, and Kamugisa is asking, are there any technology issues with using Q so far? Absolutely no technology issues, because you as a nurse and me as probably a nurse, we simply need to take vital signs of this person, and a particular interest will be paid to respiratory rate, that any person with a respiratory rate more than 22 is trying to say that the organ for respiratory system is actually failing. And secondly, if the person has systolic blood pressure less than 100, potentially one of the causes could actually be sepsis. And the third thing is that if the person has altered mental status, which usually presents with the agitation, confusion, sometimes maybe the person is unconscious or lethargic, these are pointing to sepsis. These are the three parameters which QSOFA actually uses to raise level of suspicion, and no technology issue at all. And the other question probably is about I think Paddison asked about are these related to institution, or are there institutional challenges in implementing this? Absolutely no. Because if every institution in Uganda hospital allows nurses to take vital signs, allows nurses to take observation, and it is simply about taking observation and interpreting, are we having a safe vital signs, or are we having a vital sign that is probably abnormal? Simple. So you do not need anything that can hinder you from using QSOFA to trigger your level of suspicion that somebody is actually having sepsis. And the bad news is that if someone has more than 2 parameters, the chances of this person dying in the next 24 hours, it keeps increasing. And any delay by 1 hour increases the rate, the risk for mortality by 7%. And that's very great information that we need to make use of in our clinical setting. Thank you.
Thank you very much, one of our leaders, lecturer at Aga Khan and president of Clinical Care Association Uganda. I think that resonates really well with myself, having done some professional volunteering in one of the referral hospitals, and sepsis indeed would have been easily identified if the early warning, the SHUS score were carried out. So, checking the vital signs in early detection for infection is really important. Thank you so much, Ms. Ali, for that poster. We're looking forward to sharing it with all our colleagues in our conference booklet at the end of the conference. I would like to request kindly if maybe Winnie is able to read out some of the very good comments for you about the 2 presenters. From Shamim Mukasa, your research on sickle cell is really, really inspireful and a very useful knowledge. I did not know most of those things myself. So Winnie, would you mind please reading out some of the very good comments that our participants about these presentations? Thank you very much.
Yes, okay, thank you so much for the opportunity. What I'm seeing here in the chat box is good presentation done. Thank you, my concerns are addressed. That was, I think, to Mr. Cliff Aliga.
Thank you, I didn't get that, my network just dropped down. Was there another question apart from the ones I've answered?
No, there was no. We're just being encouraged by the good comments from the participants about your presentation and Shamim's poster presentation.
Great, thank you so much. And I hope all the nurses here who know this will be able to implement some form of implementation. And if there's anybody or any nurse across the country who needs any support, please just feel free to contact me anytime. And I will tell you exactly how to apply this tool.
Thank you.
Temperature is one of the parameters in MIO, modified early warning scores, but it's not a very important component of QSOFA, but it can be a component of modified early warning score. And it can also actually still indicate that there's some sign of infection. But even if it is not there, still we can still go ahead and use the 3 parameters I told you earlier.
Dr. Cliff, we want to know more about the availability of this tool. How can we access it? And probably is there some training for people to use it, how people can apply it in different parts of the country? Because this is probably quite to the Kampala, but how about people in peripheral parts of the country? And is it available? Is there a training that probably you are already with the Ministry of Health, how all those workers probably learn how to use it and be able to assess their patients and reduce this mortality rate and severity?
Great. I will give my telephone number for those of you who would like to have this tool shared. I will type my telephone number here on the chat group. On the chat, so that you can give me questions or any idea if you want to use this tool. Yes, the tool is available. I can actually say it, and please, it has a very simple training that takes about 2 hours for you to implement it. It's very simple. And you can roll it out immediately. Nothing to do with the very intensive, something to do with the how to implement this tool. A very great tool, very easy to use. I'm glad to share my telephone number for you to contact me directly, and even my email.
Thank you very much, Cliff, who has shared his email and telephone number. I would like to shout out to some of our colleagues in the different referral hospitals. I see Sister Nasuna at Mulago. Thank you very much, Sister. Would you like to say a word or two, please?
Good afternoon, viewers. My question goes to Mr. Cliff. Is it cost effective to carry out that test? Thank you.
Hey, great Nasuna for that question. Yes, the procalcitonin test can be done. In terms of cost, it costs between 25,000 to 30,000 if you go to private practice. But the equipment, for example, the equipment in machine in Mulago Hospital, for example, the Cobas machine, even in many of the hospitals that are running sepsis tests, they can actually test procalcitonin available. But all this depends on the clinician, because the tool that I'm simply giving you, it does not necessarily require you that you must have the test done. Because what I did in this study was simply to confirm that if we identify the persons using Q-SOFA, will their blood sample show that there's an evidence of infection? And surprisingly, all the persons that we captured with this Q-SOFA had an evidence of infection at various level. And the control that we put in this study was using complete blood count, where we looked at the neutrophils, the white blood cell counts, which is routinely done in our facility. So this tool will simply identify for you persons who are at risk of sepsis at a very early time. And then the doctor can actually request to confirm, either using a culture and sensitivity, which takes about 72 hours, or if the person can afford, or if it is within the cost affordability of the facility, they can run the procalcitonin test. And the machine is available. I think Rubaga Hospital has that machine, Mbarara Hospital has the machine, and I think Mulago Hospital has that machine, which particularly was developed for body tech. And you can use that machine on the bedside as you are doing a ward round. You can actually use that machine to test this kind of procalcitonin. Yeah.
Thank you for your presentation. I'm Grace Nakos from Bara University. I want to find out how this evidence base you are putting forward can be incorporated now into practice. You mentioned that the machines are in Barara, Mulago, and the Zambia, and Rubaga. Yes, Rubaga. How can we roll this in a more organized way so that all nurses can appreciate and implement this kind of findings? However, you also clearly mentioned that this study was funded, meaning some of the things before. And yet, oftentimes our patients are the one meeting the cost of their laboratory tests. And most patients who come to our hospital come when they do not have enough. But I'm wondering how we can make this interesting finding more applicable in our healthcare systems, where we find that the machines at times give us wrong, faulty measures. So from your own experience, how are we going to marry this so that we take it on? And what measures have you actually put in place to roll this and also involve Ministry of Health so that this important finding can be utilized? Then my other question is to the presenter of sickle cell. This is interesting and I'm really happy that it has come out. However, how can we empower the community to appreciate this further? And also, how are those people who are now finally diagnosed with sickle cell going to move on? Remember, somewhere the attitude was, I don't want to know whether I have sickle cell so that I live worrying. So finally, when you have sickle cell, what next? Is there some kind of plan the study came up with to help those who didn't want to know, but now they have been diagnosed, but yet they must carry on their lives and live with the disease? Thank you.
Great question from Dr. Grace Mbarara, and excellent, observation. And yes, Dr. Grace, this study probably, I will probably say, was probably at a pilot phase, and it will have been better to expand the scope of this study, probably in many facilities. That will be one of the recommendations that I will make. I would like to say that this was enough for us to move on and then start implementing. But it could have been better if you really want to integrate in the evidence-based practice. And then that means we expand this implementation of the study in a wider range. And if we can do that, that means we must adopt and adapt the tools that actually this study used, and probably validate, the machine that I used particularly, which probably the validation was part of this outcome, because I compared this machine with the routine machine, the routine test that has been used in Molago with, for example, the routine machine which are used in Molago, any regional referral hospital or anywhere in this country using CBC. So when I compared the findings of the presence of procalcitonin with the parameters that indicate there's an infection, it was very clear that yes, it was able to predict. But that's not the core thing. The core issue is that can we use clinical signs to identify patients who are at risk, even if you don't have the machine? Because many of the patients, 80% of the patients who have sepsis actually do not get sepsis from the facility. They actually come with sepsis, and more likely they are in lower health facility, in health center 2, health center 3, health center 4. Probably that's where the machines for complete blood counts are not even present. So if we use the clinical signs at a larger scale and interpret the result and conclude that probably yes, this probably QSOFA can actually identify patients, then it wouldn't be much better that if the patient doesn't have money, we'll go ahead and initiate treatment, because the machine has, the finding probably is that the evidence is that yes, QSOFA can predict that this person is suffering from an infection. But what the QSOFA machine does not do, I mean, the test that I did does not show is what is that particular infection. We are aware that sepsis can occur from any infection, whether it is a parasite, whether it is a bacteria, whether it is a virus. Sepsis can actually originate from them. So that machine doesn't do. What can only happen is if you do a culture and a sensitivity. But our worry is culture and sensitivity result takes more than 72 hours, by then which will have prolonged the chances of this person dying of sepsis. So the issue here is that, yes, we can carry a larger survey to gather more evidence, and they agree through the policy making mechanism in this country that we adopt a particular way of taking vital signs or of taking observation to screen this person. Number two, that we should actually raise awareness all over the country that sepsis is imminent. Sepsis is prevalent in our country. Many patients are dying because of sepsis. The final pathway of which a person dies is usually sepsis. And these are not recorded, these are not reported, these are not actually captured in our HMIS data that a person has died of sepsis. You find out the person, they said the person has died of pneumonia, has died of malaria, but the final cause of death in any of these, many of these patients is usually sepsis, which is not actually captured. So we may have to improve the way we capture our data as one of the parameters to escalate this kind of method all over the country. I will be available to have any CME to be run on this particular queue software so that we can train nurses on how to apply it. And then you can individually take the initiative within your facility and within your scope that work together with the system that is there, whether the directors or the clinician, that there is a new way we can try to screen patients, and please help us request for the right investigation, because requesting for investigation is not the mandate of nurses, it's the mandate of doctors. If we can work as a team and adopt this tool and put them in our clinical practice, definitely we'll have a very great work. I thank you. I hope, Grace, that answers your question, and probably we'll have further discussion beyond this conference about that again.
Thank you, Mr. Keith. Maybe before you finish, I wanted to ask, why did you exclude maternity? Because these mothers, they also get sepsis and they end up in pulmonary sepsis. So I was wondering why you excluded obgynecology.
Okay, great question.
Thank you. Yes,
there was no, I know it wasn't a good idea to exclude them, but the availability of resources could not allow us to expand it beyond what we were able to do. And you know, this resource and the time was a factor, and we thought having this as a pilot will give us an idea, so that probably in our next phase will include maternity. And yes, many of the patients who actually are admitted in surgical ward with infection were among these patients, especially post-operative mothers. I remember seeing patients who were operated in other lower facility and they came with the symptoms of sepsis, and they were actually captured in this study. What I haven't told you is the characteristics of a patient's diagnosis in this, and the post-operative sepsis was one of the conditions which was associated with these symptoms that I indicated earlier for you. Yeah, indirectly they were captured, but not deliberately done. We did it in maternity department. Thank you.
Thank you so much, Cliff, for sharing that very, very interesting and very informative presentation. And thank you for providing your details so that the audience and members can contact you to learn more about the wonderful tool. We are now going to move on, please, in the interest of time, and introduce a subject we touched on earlier, the nurse practitioner and advanced nurse practitioner example. It's a colleague I'm privileged to work with, Mr. Young. Musa is a lead nurse practitioner at Moorfields Eye Hospital. He's been working closely with Uganda to support the eye health department and our nurses. Musa recently presented to an audience of 10,000 nurses. So Uganda is very privileged to, have this resource. Many countries do not have nurse practitioners, or they cannot do some of the things we are doing at Moorfields, or even, doing in Uganda now. So thank you, Musa, for your time, and we welcome you on stage. Thank you. Musa there? Musa?
Let me check if he's online, Primrose. Thank you.
Thank you, Beth. So while we wait for Musa, if there are any other questions, please put them in the chat box or send them to the email provided so that we can compile them and feedback after the presentations or the conference. Thank you so much. Again, as we wait for Musa, I'll just share some of the examples that Musa, as an advanced nurse practitioner, has done or does on a daily basis. He is actually at work running and leading the cataract clinic. Because of COVID, Moorfields has had an influx of presentations with cataracts. So the volume is quite high, and Musa is one of the leaders leading the clinics. Musa is also the lead for glaucoma. He runs nurse-led clinics for glaucoma. He can diagnose, screen, diagnose, and actually teach doctors regarding some of the interventions. So recently he had a teaching session which involved Uganda to help us learn more about glaucoma. In some areas in Uganda, glaucoma remains undiagnosed. So we've got Moorfields who are happy to teach us and share their learning so that we can also be able to screen, diagnose, and treat these conditions. The other thing that Musa does, he's an educator, clinical educator, and he actually manages 6 sites. We've got the main site at Moorfields, but then we've got outreach clinics. So he leads 6 of those. And those are just examples of what the nurse practitioner can do to support the multidisciplinary team, especially the doctors who are overwhelmed sometimes. Thank you. Any news on Musa, Beth? We may have to make...
He's coming. He's just sharing his slides now. Thank you.
Thank you so much.
Okay, I had wanted to share on the sickle cell mother we had recently on our maternity, Mbarara Regional Referral Hospital. Recently we had a blind grab that exactly what Namka was sharing. It's what we had on the ward 2 weeks ago. And we had, of course, managed this mother, and fortunately enough, she had a normal delivery, which we were all happy. Only that at first we were so scared, but because she could develop high-grade fever, but we tried to manage it with analgesics, and eventually the mother delivered, which was also very good to us as health workers. So I'm really appreciative for what Namkas was discussing. Thank you so much for listening.
Thank you, sister, from Barara for sharing that information. And these are all learning examples that we can all take away and improve upon. Thank you once again.
Okay. I'm Asima Anet from Lagos Hospital. My question goes to Mr. Cliff. Many times we've got patients with VAP, and usually patients with VAP take long in ICU. So what happens to families that don't have enough financial help? Is there anything done by the government to support such families for the drugs used to treat the sepsis? Thank you.
Thank you. Sorry, I didn't get your name, but very good question. Ventilator-associated pneumonia is a very common problem for patients who are ventilated, who are intubated. And the issue is that sepsis does not only come abruptly. Sepsis takes a longer time to manifest. It takes a longer process to appear in patients. And it appears right from the community through our emergency department before the person ends up in ICU. Usually a person, when they end up in ICU, they're intubated. And when they end up in ICU and they're intubated, the issue is still again under nursing care, because ventilator-associated pneumonia can be prevented. It's not that everybody must get a ventilator-associated pneumonia. If a person gets ventilator-associated pneumonia, then the problem is coming from the care providers. One, when you are turning a patient, always remember to clean the mouth of the patient before you even attempt to turn the patient. Because when you turn the patient before cleaning the mouth or providing mouth care, you risk causing this person, the infection that are originating from the mouth. Great thing that nurses do usually every 2 hours, they usually tend to forget cleaning the mouth before they turn. The procedure should be that clean the mouth of a patient before you turn. Even in our routine care of patients who are unconscious, it is part of the process. So before a person ends up having ventilator-associated pneumonia, as he said, it takes a longer time for them to recover if they really have to survive. And when they survive, they actually survive with the complication. So the issue is, can we improve our clinical care? It starts from there. And putting the issue about the cost implication, obviously these cost implications need to be prevented by doing the right thing right from the beginning when this person has access to you. You might be that nurse, or you might be that health worker who found this person in the community, who found this person in the OPD, who found the person in maternity. Mention any word before this person reaches ICU. Let's do the right thing. The right thing is, let's protect them. And secondly, patients who have catheters, they are at a very high risk of developing sepsis. So the issue is not about can the person afford. The issue is what can we do as nurses to prevent. The patients will not afford. The hospital will not definitely afford. It is our mandate to prevent all this. Not every person must get sepsis. We can actually prevent all these infections that patients end up with in ICU. So the issue now is, can we improve the caliber of nurses who work in this facility? Can we train our specialist nurses? Can we train those who are already working there so that we equip them with the right knowledge? You might be very happy that you're working in ICU, but are you well equipped with the knowledge to do the right thing? That should be the question that we need to ask ourselves. We are not going to wait for government to put a very fancy facility. We must do our part as nurses right from the beginning. Thank you.
Thank you, Cliff. Maybe a time for one more. Anyone with a question while we wait for our next presenter?
For that presentation once again, but we are aware that most of our patients come already with infections, as you say. So what measures have we put in place, or did this study put in place to help the community be aware that they really need to be responsible and take care of themselves so that we minimize the infection? Thank you.
Yes, once again, Dr. Grace, talking about the community, and I've just said that sepsis starts from the community. That means the Department of Community or Public Health needs to be strengthened. We need to empower our patients. And even before we reach the community, any patients who come to facility, we need to empower them. The issue of, for example, dispensing drugs to patients, they say, oh, go and take this 1 times 3. or twice in a day is not enough. We should go further than that. Say, go and take this drug and prevent yourself from getting infections. Those are the basic things that we can do. Beyond that, this study did not put any mechanism in place, but the mechanism that probably I want to promise is that we need to do continuous medical education about making ourselves aware about these issues, because we can actually prevent them. And those of you who go with the medical students, nursing students to community, it should be one of the aspects that these students will go to the community and talk about. Let's use all avenues, the local council, the church, the cultural leaders. Let's make use of them and empower them with information. Thank you.
Thank you, Cliff. Thank you so much. I think we probably need to plan a presentation with yourself very soon. So thank you so much once again. We now have our next speaker, Musa. You're welcome. Thank you.
Musa.
Hello, can you hear me?
Yes, we
Yes,
can.
we can. We can.
All right, sorry, I must apologize that I'm a little bit late to come in. When I saw 1:30, I thought it was 1:30 GMT, so I was preparing for 1:30 in the afternoon. My name is Musa. I work at Moorfields Eye Hospital in London, advanced practitioner in glaucoma. I would like to thank the organizers for this conference. And my topic today is on advanced nurse practicing and specialized nursing, a case for ophthalmic nursing. I would begin this presentation with the words of Wendy Reed. Wendy Reed was the National Clinical Lead for European Working Times Directives. And she said that patients no longer care about what title you hold. It is more important that you have the skills to deliver the care. This statement reflects the dynamic change in the mindset of an average patient and their expectations, and is one of the reasons that help to shape the role of specialist nurses in all fields, from diabetic management, dialysis, chronic disease management, and ophthalmology. Who is a nurse practitioner, or specialist nurse, or advanced nurse practitioner? Specialist nurses, advanced nurse practitioners, or clinical nurse specialists are titles commonly used to describe advanced nursing roles. However, there is still lack of clarity in their definition. A nurse practitioner is required to have an expert knowledge. A master's degree is recommended for an advanced nurse practitioner's role. They should have the ability to make complex decisions and have clinical knowledge for extended practice. And they should also maintain their CPD, and they are accountable to their employers, regulatory and professional bodies. The development of ophthalmic nurse practitioners' role is not nationally standardized in many countries. This includes the United Kingdom and in Africa. In many areas, the process includes provision of required training by institutions themselves or by external bodies, which could be universities. Also developing policies, guidelines, standard operating procedures, and the practitioners are expected to follow these guidelines. Also include developing or assessing audit tools for quality assurance ratings and improvement, and provision of indemnity for practitioners. As you know, I think likewise in Africa, now everyone should have some kind of indemnity in case you have legal kind of issues relating to your practice. and also include creating patient information leaflets for nurse-led clinics, because patients should be able to know and understand that they're going to be seen by a nurse, not a doctor, and they should consent to that. Why the need for nurse practitioners? I'm looking at this in the UK context, but obviously these are universal problems, and you might relate to this in your own settings. So over the last 2 decades, there has been an increased demand on healthcare services. This has led to increased waiting lists and waiting times to access public services. There were concerns in the UK in the 1980s about junior doctors working too many hours, and the government report in 1991, Department of Health, recommended junior doctors working hours to be reduced by 16 hours. And the report recommended that nurses to be trained to take extended roles to fill the gap. And another driving factor was related to the number of ophthalmologists in UK and Europe. And obviously in Africa, as you know, we don't have many ophthalmologists either. So for example, in the UK has the lowest number of ophthalmologists in Europe compared to the general population. So we have a ratio of 2.3 per 1,000 population. And there is a declining number of associate specialists and specialty doctors. The average number of ophthalmologists across Europe range 8 per 100,000 population, ranging from 2.3 to 14. Population growth, as you know, is another concern, and as a result of that, we have so many elderly people in the population, and as a result of that, you have so many people with eye problems. So the demand for eye care has increased significantly. So I'm just going to talk about some of the specific roles that the nurse practitioners are involved in ophthalmology. Currently, nurse practitioners are excelling in all specialties in ophthalmology in the UK. Over the last 4 years, we have seen a surge in the number of nurse practitioners in administration of anti-VEGF medications such as Lucentis and Eylea, which is used for the treatment of diabetic maculopathies, macular degeneration, and other vascular eye diseases. Myself and, of course, my colleague who is moderating, Primrose, is involved in delivering of these injections. Before the nurses started administering this treatment to patients, it was mainly a treatment given by doctors only. And there has been a lot of discussion about whether the nurses should be allowed to deliver this treatment to patients. And you could see the pressure on the nurses to be able to prove to everyone that yes, this is possible. So the nurse's role in this includes assessing patients as well as actually delivering the injection to the back of the eye, which has a lot of risk factors, including patients potentially could lose their sight. This is the statistics of injections delivered by nurses, myself included and Primrose included at Moorfields Eye Hospital from 2013 to 2018. Over the last 5 years, the number of intravitreal injections performed by nurse practitioners have increased at Moorfields from just over 1,000 patients in 2005 to over 3,500 patients in January 2018. So you could see there has been a significant increase in number of patients that have been injected by nurses. And just to give you a little bit of safety record of nurse practitioners who have been delivering this injection, This is compared to other trials that's called by the Marina trial and the ABC trial. These two trials are performed exclusively by the doctors. So if you look at the top one, which says endophthalmitis, that is the infection rate, nurses injected about 25,000 eyes during that period. And out of the 25,000, only 5 patients have infection, which is equivalent to about 0.02%. If you compare that to the Marina trial, which is mainly done by the doctors, they also have five patients who have infection, but if you look at the number of patients they injected, it's like half of what the nurses have injected. You look at another one, which is retinal detachment, which is another complication, nurses have 0. And compared to the other trials, they have 1 each. And all the way down, nurses have less complications compared to the procedure performed by ophthalmologists. So this has proved that it's possible. This has proved that nurses are capable to do this and do it safely as well. Next slide, please. Okay. In glaucoma surveys, nurse practitioners have contributed immensely in reducing waiting times. Just, if you guys are familiar with the healthcare system in the UK, you know, once patients are referred to us, we have 18 weeks period in which we have to see and at least deliver the first treatment to the patient. But because of the number of referrals that we have, sometimes it's almost impossible to meet these deadlines. But the involvement of nurses in care has contributed immensely in reducing this waiting time for patients and as well as improve patient experience. Glaucoma nurse practitioners manage their own caseload independently. We make autonomous decisions. We help in teaching, training colleagues. We do provide patient education on their conditions so that patients understand what it is and also comply, not only understand, but comply with medication, because these are long-term conditions and they need to have treatment almost for the rest of their life. So if someone doesn't understand what they have, they are less likely to comply with whatever treatment you give them. We also undertake clinical audits just to improve services that we run. So the nurse optometrists and doctors all work in conjunction in a multidisciplinary team in cataract clinic. And our work involved assessing anterior and posterior segments of the eye for any abnormalities. The part of the nurse practitioner's extended role is also to discuss refractive outcomes. So we are able to explain to the patients, these are the options we have for you. The previous one, please. Just completing that. Okay. So we are able to explain to the patient that we have different options of lenses available and what are the implications of having those lenses in their eyes. And based on that, we could consent them and then list them for surgery as well. And we are also able to assess patients and discharge them. And those that are complicated, we have to either discuss with our doctors, colleagues, or refer them to consultant-led clinics. So another area in cataract service that we are involved in, this is something that I'm involved in as well, is YAG laser clinics. So YAG laser capsulotomy clinic is mainly run by nurses, like independently run. And these patients are referred to us either by optometrists from the high street or also from other consultant-led clinics. And in the clinic, what we do is we check history. Obviously, we do check patients' vision, measure their pressures, dilate, and we do straight lamp examination to confirm the diagnosis and actually deliver the laser to treat the patient. And this also includes consenting as well. There are other specialist areas in ophthalmology that we have our colleagues are doing extremely well. For example, in cornea clinic, we have nurses undertaking what they call cross-linking to treat a condition called keratoconus. Treatment is delivered safely and effectively as per audits. In ophthalmic emergency clinics, we have nurse practitioners who work there independently, see and treat patients. And in oculoplastic surgery, we have a lot of our colleagues who are doing minor surgeries. So the benefit of nurse practitioners or advanced nurse practitioners, whatever you call them, is just the benefit is vast. Yeah, high number of patient satisfaction is recorded according to the audits that we have conducted across all nurse specialist clinics. There is more time for ophthalmologists to concentrate on surgery and seeing more complex cases, greater efficiency and reducing waiting times for patients. We are regular audits to ensure patient safety. We always have positive patient experience, and also it's good for continuity of care and also increased job satisfaction for nurses. And finally, I would also like to discuss about the rapid changing role for nurse practitioners in ophthalmology. This is because of the, as you all know, these machines, the deep learning machines and AI technology. Currently, myself and some of my colleagues are involved in a study where we are looking at, well, as part of the support team, we are recording all surgical procedures, and this information is going to be used to develop some kind of software for robotic, hopefully robotic cataract surgery in the future. So nurses have a great role, and our contribution is very essential as far as ophthalmology is concerned, because at the end of the day, we have so many patients to see, and no country, even in the advanced world, where you can have enough doctors to be able to see and treat these patients. And on that note, finally, I would like to conclude this presentation with the wise word of John Pinto, who said, change is inevitable, prepare for challenging features in ophthalmology. And I thank you very much for listening.
Thank you so much, Musa.
Okay, thank you so much. That was absolutely fantastic. And I don't know about everyone else, but the big takeaway for me was not about the title, but the skills to deliver care and just the proficiency in which the nurse practitioners carried out those very complex skills. And certainly in my own working life, I know people with bigger and fancier titles not qualified to carry out the same skills because of the training that we've had in our roles. So that's brilliant and very encouraging. So thank you, Musa, for your ability to jump on at very quick notice and impact the people who are hearing your message. So thank you, sir.
Thank you.
Okay, so next we have our moderator for the next session, Mr. Ronald Kamoga from CFOVID. So handing over to you, sir. Thank you very much. Just remember to unmute, sir, so we can hear you. Thank you very much.
Hello, you can hear me now?
Yes, indeed. Yes, we can hear you loud and clear.
All right. The next person to come online is the chief lead the chief stroke lead panel of judges for NHCC 2020, Mrs. Rosie Chiwanuka. And you're most welcome, madam, if you're online.
Thank you very much. Indeed, I am online, although I'm in troubles, but I've stopped to make sure that I make this presentation. And I request that if I go offline, just know that those are the challenges we face here in Uganda. Some areas have no network. As you have rightly said, my name is Rose Kiwanka.
Yes, you can go on.
I am a palliative care nurse. I've been and I'm a founding director of the Palliative Care Association of Uganda, currently retired, enjoying retirement, but focusing on primary health care. My discussion is on improving clinical practices through documentation, a very important area, documentation. And as nurses, definitely documentation is what saves us. So what do I have to say? Nursing documentation is the record of nursing care that is planned and delivered to individual patients by qualified nurses. Very important. Nursing documentation is very essential for good clinical communication. Its appropriate documentation provides accurate reflection of nursing assessment, changes in clinical state care provided. It provides important information that supports multidisciplinary to deliver great care. And my question is, are we providing the documentation in the right way as nurses? And I believe we are. And if we are not, I would encourage all nurses to do that, because really it is the documentation that can help us to show that we are doing a great job. What is the purpose of documentation? The purpose is to communicate, because even the person who is not there will get to know what is being provided, what aspects have been done and what is not yet done. So it provides efficient and effective method of sharing information. Legal documentation is admissible as evidence in courts of law. You can be able to stand you can be able to stand and say, no, I didn't do that, I did this, and here I am, I documented it. And there will be evidence. But if there is no documentation, then that just poses a big challenge. I remember yesterday, somebody gave a research paper on documentation, and she highlighted the challenges of documentation which is faced by the nurses. And there were comments that at times we are very few on the ward caring for so many people, so we don't document. But I'm telling you, if the law comes in, you may not be saved. You may not get away with it, because documentation is a big requirement. Okay. Okay, I'm there with you. Purposes of documentation, it facilitates research, and this is the researchers we are talking about today. Documentation provides valuable health-related data for research, very important. If you don't document, research can be very difficult to be undertaken, because there is no way we are going to base our research on. It provides statistics, which is very important, information that can be utilized for advocacy and planning for the care of these patients in the future. But also, students learn from what we document. If somebody comes and studies the medication, rather the patient chart, they will be able to learn from what you documented. But my question is, are the nurses, especially in Uganda, allowed to document in the patient's charts? That I cannot say yes or no. You know better because you're in practice. Documentation provides for education, as I say, and it serves as an educational tool for students in health discipline. Nursing documentation, I can't emphasize it enough, is very, very essential, because what is not documented is not done. There is no way you can convince somebody that you did something when you've not documented. Today, I'm so happy to see the various pieces of research work done by nurses. They have documented, very, very important. And these research results will inform and help us to improve our practice.
You've heard it.
I am glad that judges accepted to widen the scope of the research of the abstracts, so as to allow in more abstracts to come in, so as to allow nurses to share their work. And this forum is really helping us to share our work, to learn from each other. Nurses have been doing research, but probably they were not getting an opportunity to share their work. And that would mean that nurses don't get involved in research. And what we've been seeing, that nurses are not leading, but they are helping. They are just supporting other researchers. But I'm glad here we are coming out as lead researchers. We've had a number of papers coming in from infection control, service provision, palliative care, education and training. And these are various abstracts or research pieces of work which were submitted for review, have been reviewed by the judges. So I want to thank all the judges for the great job that you did. It was a great, a big exercise. They did various review of the abstracts and came out with the best abstracts. As you have heard the presenters present their work, I would therefore like to say, or to end by saying, all nurses should get involved in research. These studies will help us to change the world. Let us all work together and improve documentation for the good of our profession and our own patients. Thank you very much for listening to me, and I wish you a good conference. I'll try to continue listening, but I might lose you at a certain stage when I get in an area where there is no network. Thank you very much.
You're most welcome, Mrs. Rose Chiwanuka. And she has said it all. And I'll summarize it by saying, any work not documented is no work done. That takes it all. I'll return the mic to the chief moderator, Mr. Pearson.
That is an absolutely great comment, sir. So thank you very much for that. So we now hand over to our next presenter. So we're looking at a presentation from our Stakeholders Day 2. So this is the online learning tools. So World Continuing Education Alliance, that's WCEA, and we have Mr. Craig Fitzpatrick. Thank you very much, sir.
Good morning and good afternoon to everyone. Can you hear me?
Yes, indeed, sir. Loud and clear.
Hi, Matthew. Thanks for the introduction. My name is Craig. I'm a director of the World Continuing Education Alliance, or WCEA. And my role today is to give you a bit of background into the WCEA and our work in online learning, mobile learning around CPD in Uganda and indeed in the whole of the sub-Saharan African region. So the WCEA, first of all, the WCEA is a technology company that is based in the UK, but we've also offices in southern Spain, so right on the southernmost tip of Spain. So we're as close to Africa as we can possibly be. So what we specialize in doing is providing sustainable innovation tech solutions to ministries of health, nursing and midwifery councils and professional associations to help build capacity in CPD and lifelong learning. We have a global partnership with the International Council of Nurses. So WCEA and Project 2020, this idea emanated from the WHO designating 2020 as the year of the nurse and midwife. And we decided as a company that investment was needed in nursing and midwifery education, especially in low and middle income countries. So we set about setting up platforms. So what we do is essentially provide branded CPD compliance platforms, e-learning platforms and mobile apps, which are embedded with resources of free CPD from globally respected education providers. With the goal of improving access to quality education, delivering better patient care and healthcare outcomes. As part of on this journey, we've obviously done a lot of on-the-ground work in Africa, and I've traveled extensively throughout Africa over the last 2 years and met key stakeholder partners. But as part of that, around the technology, we've also done a lot of research. So in particularly around smartphones, and what we noticed is that there's so many applications out there, and mobile phones of nurses and other healthcare professionals in Africa do not have the disk space for multiple applications. So what we've decided to do is try and work with some of the leading educators around the world and advocate for all that education to be hosted in one central place where it's easy for nurses and midwives to access. So what we do is that the education is available through desktop, iOS, Android, and behind that is key data that can be accessed by the regulatory bodies. In this instance, obviously, Uganda Nursing and Midwifery Council, who we've got a collaboration with since January 2020. So our education partners, as you can see from the slide here, we have partnerships with the Royal College of Nursing, Royal College of Midwives, JPIGO, and many other respected educators from around the world are sharing their education into the platform. Around COVID-19, we formed a partnership with SONAM, the Aga Khan University School of Nursing and Midwifery, who've produced essential modules on COVID-19 for nurses and midwives throughout the region. So we started the project in Ghana in the 16th of January 2020, and we've been rolling out the platforms on a weekly basis with other nursing councils and professional associations over the last 7 months. So over that period of time, we have over 200,000 downloads, about 183,000 users, and just under 1.1 million courses completed in that time frame.
Sorry to interrupt. Your slides are not moving.
Oh, they're not moving, okay. Let me see. Can you see my screen?
Yes. Yes, we can now. Thank you.
Okay, sorry. So I didn't realize that, Elizabeth. My apologies. But I can share that you have a copy of the presentation, so we can send that afterwards anyway. So can you see this page, the education partners? So these are just some of the education partners that we have at the moment. We've just signed a partnership agreement with Johns Hopkins School of Public Health, and we're in advanced talks with Yale School of Nursing and Midwifery. So we're also working closely with UNMC in connecting with locally accredited providers, so that there's a nice blend of locally accredited CPD and internationally accredited CPD modules. So those talks are ongoing. So the features and benefits of the platform, so you have the ability to study online and offline. So you can download courses, it's stored in a wallet, which I'll display to you shortly. You have access to all evidence-based, peer-reviewed and accredited content. No requirement to travel long distances. Ability to store CPD activities in the app and on online platform. The app and online platform contains a CPD point counter, so you can see where you are during your CPD cycle at all times. We've just included a healthcare community where nurses are now sharing experiences and feedback on the courses, which is exclusive to the healthcare community. The platform is also going to be synced shortly back to the HRIS system with the council. So effectively what we're trying to do is move away from paper-based recording of CPD. So it means if you study and complete a module, that it can be synced back to the online services portal or HRIS system used by UNMC. UNMC has also got tools that allow it to view the demographics of users, age and gender profiles, types of nurses, and actually live feedback on the courses themselves. So just a quick summary before I move on to the virtual presentation of the app. To date, we've, as of last Tuesday, we had 5,164 users in Uganda and 11,100 courses completed. So I think in Uganda we have about 60,000 nurses and midwives. So this is an area that we're trying to work on at the moment and sensitize people. In other countries like Kenya, Ghana, Nigeria, we've got over 50% of the registered nurses and midwives already on the platform studying. So what we're trying to advocate for is increased sensitization at all levels within the community to ensure awareness on how nurses and midwives can access and register. This can be done through Ministry of Health, nurse leaders groups, hospitals, health centers, media and WhatsApp groups. I've just included a link here where you can find to register. It's on the UNMC website and also it's on the Facebook page of UNMC. So I'm just going to move on quickly to a visual presentation of the app now, so just bear with me 2 seconds. Beg your pardon, everybody. It's not possible to pre-log into this, I'm afraid. So otherwise, it would. So, can everyone see my screen?
Yes, sir.
Okay, thank you. So this is the first thing that people see when they log into the app. They see the logo of UNMC. And then the recommended courses. So these are all at the moment, obviously, based on COVID-19. And then as you scroll down, you can then see the notifications area. So this is where we advise those that have registered of new courses that have been added and also updates on current modules. So then to move into the the main body of the app itself. We've tried to make this as user-friendly as possible. So you can search for courses here, either keying in keywords, etc., or you can go to the menu here. So you can see at the moment we've got over 300 modules available covering across all nursing specialties. And many of the speakers today have spoken about leadership, management, advocacy, and we've got over 60 modules covering those topics that have been selected by an international panel of experts, including board members of the ICN, Exicon, registrars, nurses and midwives in Africa. So you can also search by course group and also by topic. So I just picked a module here, for instance, personal protective equipment. You can download the course. You can decide to either take it immediately, or you can decide then to switch off your Wi-Fi and then go back to your village or your town and then decide to study it in an offline mode. So down the bottom here we have a wallet. This is where all the courses you've downloaded can be studied, and they stay here until you actually study the courses. Beg your pardon, this is stalling on me, technology. So there we go, beg your pardon. So what I can do then is that if I'm now remote with no access to internet, I can then decide to take the course. So all these modules have been adapted so that we make them less than 4 megabytes. They can download quickly and they don't chew up a lot of data. So, and so now I can start the course. So once I've taken the course, I'm then taken into the exam. Once I finish the exam, I then am asked to complete an evaluation and a feedback form, and then your certificate issues. So each nurse then has, or midwife, has an education tracker. This stores all your e-learning courses studied on the platform. So you can see here that it's telling me at the moment that 4.5 points that have been collated. So I can decide if I want, I can download the certificate. So the certificates have all been bespoke for Uganda. So as you will see, they contain the logo of UNMC plus the signature of the registrar. Apologies, everybody. I'm stuck in my kitchen, so that the internet here maybe isn't as good as it should be. But what would normally happen is the certificate will be displayed here. What I can also do, if I go back, there's a download button here. This allows me to gives me a course summary report, so it tells me all the courses that I've studied to date. Again, this will probably not show. Let me see. There we go. So this gives me a list of all the courses that I've studied during my CPD cycle to date, and how many points I've gathered. So going back to the menu option, I have my education tracker, I have my wallet, I have my search option where I can search for all the courses, so I can key in leadership, etc. here. And then this is the healthcare community, which is a new feature that we've recently added, where nurses and midwives are all sharing experiences and feedback on the courses themselves.
So Craig, this has been absolutely fantastic. I think we need to arrange a further webinar to delve into this a little bit further. So, I mean, it's great to know that people are already utilizing this in Uganda, but looking at the penetration into other countries, how much further it's gone. And I think the beauty of it is the fact that you don't need to travel and it's so easily accessible, and there's that motivation to do it. So I think that's absolutely amazing. And thanks for making that so visual for us. So I think what we're going to have to do now is jump over to my next speaker. I'm just going to get confirmation on that, but definitely would like to make that arrangement with you. So just bear with me a second. Okay, so next I'm going to introduce our next speaker. So His Excellency, the Ambassador of Uganda to the UK, Mr. Julius Peter Moto, and he's also patron of the UNMA UK. And after which we're going to come back to Mr. Peter Johnson from Japago. So I would just like to personally thank the Ambassador for the way he's welcomed us, you know, when we visited him in London and looked after us so well and listened to our crazy plans, but still encouraged us. And now they are coming to fruition. So thank you, Ambassador.
Good afternoon, everyone.
Hello, sir.
Can you hear me?
Yes, we can hear you.
Very well, thank you.
Yes, I want to take this opportunity to thank everyone who has taken time off their weekend schedules to attend this important seminar. It's called the Second National Healthcare Conference for today. I also thank, most importantly, Elizabeth Pearson and all the co-hosts who made this electronic version of a conference possible. Technology has now made it possible for all of us to meet virtually. I also thank Professor Maswa. I can see him online. Hi, Prof. Is he on? I can see him online. I happened to witness his evacuation from London about a month and a half ago, and I believe he's comfortably settled at home in Uganda with his people. Ladies and gentlemen, and all the distinguished guests, I accepted the invitation extended to me by Elizabeth Pearson, a lady I happened to meet. She came and met me in my office together with her husband when I reported for my duty in London. She put this together. I encouraged her actually to hold the first National Health Care Conference in Kampala last year. I'm not surprised this is the second one. I also thank everybody who has taken time off their busy schedules to attend this important seminar. We are not able to meet face to face, but technology has made it possible for us to meet virtually. I can see online people I know, people in Lira Regional Referral Hospital. Hi, everyone.
Hi.
Yes, you are my people. I know you. I know some of you one by one.
Hi.
I can see Masaka. Yes, you can see how excited they are because they know me in person. Yes, I can see Mbarara and all the referral who are represented here on this platform. Ladies and gentlemen, there cannot be any health care unless we have well-facilitated and well-equipped nurses and midwives. They form the core of healthcare in any country. Without nurses and midwives, we don't have healthcare. And I want to thank everyone, especially during this trying moment of COVID-19, who have made it possible to render services to Ugandans and visitors to Uganda during this critical moment of COVID-19. Not long ago, Uganda's healthcare system had actually virtually collapsed. I happened to witness the looting of Lira Regional Referral Hospital. Everything was looted from the rooftop to window panes. There was nothing left, including toilet seats. Most hospitals suffered the same fate of Lera Regional Referral Hospital in 1985. Now we are in 2020. Rebuilding of the healthcare system and infrastructure has not been easy. And I want to thank the leadership of President Museveni, working with key persons like Professor Maswa, who at one time was the Director General for Health. They put in place a strategy for health care rehabilitation. That's why we can now talk proudly of regional referral hospitals with the associated health center 3s and health center 4s. Now we have staff and we have equipment. We have continued to re-equip these hospitals which were looted to nothing in 1985. Am I lying, ladies and gentlemen? You are at the forefront. Can I hear whether I'm lying or not?
It's the truth, sir.
You're right.
You're right, sir.
Yes. So the history of rehabilitation of our health sector has not been a smooth one. Even up to now, government of Uganda have continued to build capacity. And this National Healthcare Conference has come at the right time when we need all the brain power. In the past, we used to talk about brain drain. Now we can talk proudly about brain gain. The previous presenter gave us a very good website with a list of courses that you can use to upgrade your brain power. You can study at any time online. You register, upload the content, read them, and apply them to improve on our healthcare delivery services. In line with government program on 5 thematic areas, for example, eradication of malaria, that is malaria control program, the control program for HIV, AIDS, and TB. Now we have corona, and all these other diseases that Uganda government has zero resources to either control, treat, and prevent. Ugandans in diaspora who are in health sector, they can contribute towards your learning, contributing materials, contributing literature and resources of websites, videos, and things like that. I told Elizabeth and Primrose Magala, I think she's somewhere, I saw her online, and a lot of other healthcare leaders who are based in the UK, that knowledge not shared is useless. You guys, if you don't share knowledge, that knowledge will remain in your head. It will not benefit humanity. Even you in Uganda, you have best practices actually in Uganda. You share it with the world, let the world know it. Put your best practices online so that even Ugandans in diaspora can share what you have crafted together in the house. You have best practices in the fight against HIV/AIDS, in the fight against Ebola. And right now you are fighting with learning, you're fighting this COVID-19. Uganda has the lowest death rates in the world after several months of registering no death. These are cases that you should upload on the internet for the world to know. Share this knowledge with people around the world. As members of the Commonwealth, Ugandans are encouraged to share their knowledge with members of the Commonwealth and with the rest of the world. So it is a two-way traffic. It is not only from UK to Uganda. Even Ugandans can share their best practices. Be proud of your achievements, regardless of the limitations and the challenges that you undergo. Lastly, ladies and gentlemen, as Uganda goes or heads into elections in the year 2021, we hope the incoming government shall continue to deliver programs that ensure sharing of knowledge and experience on the thematic areas that the Uganda government is zeroing on, so that the whole world can know what we are doing. And I also encourage Ugandans in diaspora to work with government through the Ministry of Health. Come to us. For those in London, you come to Uganda High Commission London. The door is always open. Come and we share a cup of tea from Uganda. Come and we share Ugandan coffee and many other information that we can be able to avail you. We are here to help, and I wish you the very best, ladies and gentlemen. Thank you very much.
Thank you, sir, for taking time out of your busy schedule to speak to us and encourage us. And it's just great to know that the COVID cases are so low in Uganda, so what's going on has been so effective. So thank you. We hope to see you in person for the event next year.
Yeah, I will be able to attend, hopefully, yeah.
Thank you, thank you. Okay, so next in our program is the closing ceremony for the second NHCC event, and that obviously for supporting nurses and midwives, and the remarks are by the Honourable Permanent Secretary, Ministry of Health, Dr. Diana Twine, and patron for the NNC Uganda and co-chair of the UKHA. Thank you. So as we wait for the Honourable Permanent Secretary to sort of log on, what we'll do, if we're able to, we'll look to speak to Peter Johnson from JPAGO. So if we can do that, Mr. JPAGO, to come on and speak about your input, sir.
Thank you very much. I'm happy to. I'm also happy to cut this short if it helps. I'm Peter Johnson from JPAGO. I'm the Senior Director for Nursing and Midwifery, and I send greetings from our country director, Uganda Country Director, Emily Katarkawa, who is unfortunately unable to attend today. She asked me to speak on her behalf. What I'd like to do today is talk a little bit from the perspective of the State of the World Nursing Report that was released in April of this year on World Health Day, and is at a point of readiness to be moved from report to dialogue and hopefully some decisions and some investment in the things that were highlighted in the report. So just to start by saying the State of the World Nursing Report, along with the Triad Statement and the Uganda Country Profile, as well as a labor market analysis of nursing that was conducted by World Bank, ICN, and JPAGO back and Exicon, I'm sorry, back earlier this year, all should inform action moving forward. The process of turning this landmark report from 204 WHO member countries that was conducted into action has been impeded a little bit by the COVID context that we're all working in right now. I think people felt like the plan was we would dive right into action and making decisions around the report, and having these national conversations, important national conversations, letting folks know what was needed, and driving quick investments and quick wins. I'd like to ask that we look at the COVID context as an accelerator of this now that we are moving forward. I think nothing has called the world's attention to the need for nurses like COVID has in recent days, as well as I think the challenging context that nurses must work in. And the State of the World Nursing Report, which is focused around education, jobs, and leadership, all have been impacted by the virus and our response to the virus. So let's let it be an accelerator as we move forward. The things that you'll find in the State of the World Nursing Report, and they're emphasized in this labor market analysis that was done in your region, as well as the triad statement that was conducted when nurse leaders met around the world a few months ago online, and what you see in your country profile should drive a dialogue process that will be that can start at any point right now. Things that we're going to be looking for and things that come out as being important are the need for better data on the profession of nursing. And because the State of the World Nursing Report was driven by the WHO National Health Workforce Accounts, I would say that we have better data on nursing in Uganda and across the world than we have in any other health profession. But there's still a lot of missing information that we need in order to be able to make good decisions. Gender equity is essential. I think set in the profile from Uganda, 70% of the nurses in Uganda are female, and there is still a glass ceiling for women even within our profession. We need support to our regulators. The good work that Craig was talking about with the councils. The councils need resources in order to be able to support that, make sure that people have the CPD, that their education programs are accredited. These things require resources that just aren't on the table always right now. Nurses need leadership development in order to be able to drive quality education, in order to be able to drive jobs. We need to be able to, the speaker that talked about advanced practice nursing earlier was, I thought, incredibly compelling, and there's a whole variety of roles that nurses can step up into that go beyond the basic core competencies that a nurse leaves their pre-service education with, but that's going to need additional education. It's going to need additional regulation, scopes of practice that accommodate that advanced practice so that nurses can have a career where they grow and as WHO's goals are, making sure that every nurse practices to their optimal scope of practice. And then the one thing that I just want to highlight is the need for intersectoral support, making sure that those people that don't understand nursing or have misunderstandings of the complete role of nursing that are capable of driving change and pulling some of these levers that we need pulled are at the table with us. My boss, Leslie Mancuso, always says, if you don't have a seat at the table, pull up your chair. We need people to be making room at that table as well, so people are comfortable pulling up their chair. And then finally, the one thing that comes out in the State of the World Nursing is that in many places, nursing isn't a first choice profession for young people. And I think just want to encourage folks to change that. We want folks to really understand how exciting a career pathway nursing can be. And get them to not look at this as a fallback or a stepping stone to something else, but something that has unique, incredible value and really rewarding. So JPIGO has a contract with WHO to support the policy dialogue process at a national level. I encourage you to reach out and talk to Emily in our JPIGO office about possibilities to support that in Uganda. Reach out to the WHO country office to talk about your readiness. First step in this process will be to connect the nursing community, figure out who those other people are we need to bring to that table, and have the conversation so that we can move that dialogue to decisions and those decisions to dollars for nursing. So I will just finish by saying thank you all for your dedication, your leadership, and for those of you that are in clinical practice and in the trenches, thank you for your heroic efforts. Really honored to be with you today. Thank you.
Thank you very much, sir. Do we have any quick questions for Mr. Johnson? That was very interesting. Any thoughts from the floor?
I want to appreciate Johnson and the JPIGO as well for for coming down to Uganda and support our country. Thank you very much, and more especially supporting us nurses and midwives. Thank you very much.
Fantastic, thank you. So now, just before we wrap everything up, we're going to move into a break. And so again, the request is, if you have the opportunity, please post about this great event on social media. We just like to send a message out to acknowledge our stakeholders. So these are the Ministry of Health, Seed Global Health, Shirley Baines, Chair of the Board of Directors of the Burdett Trust for Nursing UK, the Uganda UK Health Alliance, the Commonwealth Nurses and Midwives Federation, the NHCC board members, Zone 1 Hearing, Nursing Now Uganda team, JPEGO, ICN, World Continuing Education Alliance, the Uganda UK Health Alliance, thank you, Moorfields NHS Trust, CFOVID Uganda, the iHealth Africa, and Young Nurses and Midwives Leaders, and anyone else who we've not mentioned who's helped us with this journey. So regarding the hospitals, we'd like to give a special shout out to Hoima, Fort Portal, Lira, Arua, Mbale, Lubego, Mulago, Mbrera, Iganga, and Masaka. So thank you all very much for attending, and we're going to hand you over to our next speaker very soon. So just a quick comfort break and chance for you to interact on social media.
Future global health.
So our next speaker, speaking on paving a new fraternity, advancing and embracing change, is Dr. Rose Clark Nanyonga, Vice Chancellor, Clark International University and patron of the NHCC Uganda. Over to you.
Can you hear me?
A little bit quiet, but we can hear you.
Is that better?
That's fine. Please proceed. Thank you.
Thank you very much, ladies and gentlemen, invited guests. I'm delighted to be here one more time and to see so many of you turning up for the second day of the National Healthcare Conference, the knowledge sharing platform for nurses and midwives. I have 5 minutes to make my remarks, and I very rarely violate that time. Thank you so much, Elizabeth Pearson, for bringing us to the table one more time with a specific focus on nursing and midwifery and how we can all collectively raise the profile of nurses and midwives in Uganda and globally. I have listened with intent on the majority of the wonderful things that have been said here today. And I want to capture a few things that were said today because we got a summary from what was said yesterday. Dr. Safina, in her remarks, Commissioner Hussein said, we need to have practitioners with advanced nursing leadership and management skills. This was echoed by various other speakers on the platform today, and I believe that's an important takeaway for all of us, including the SNOs and SPNOs who are on the call from the various regional referral hospitals that were enabled to attend this conference. Professor Omaswa reiterated the importance of leadership and why we needed to strengthen that position so that more nurses and midwives are included on the table where majority of the decisions that impact how we work and where we practice are actually made. We need to evolve those competencies so that we have something to bring to the table. He also mentioned it's important for us to have a strong umbrella under the Federation. And so I would like to encourage the nursing associations that are on the forum today, including the Uganda Nurses and Midwives Council, the Ministry of Health, Department of Nursing, our newly commissioner that was appointed, for us to really rethink this and be able to roll out the wonderful strategic plan that we already have in place. Dr. Catherine Hanaway, thank you very much for highlighting the importance of inclusion of young nurses and midwives leaders in what we are doing and how we can pave a road for them. You say it's important to invest in leadership potential of the next leaders. And my comment to you was that we need to open more doors because some of the structural barriers that keep these young nurses and midwives leaders out of the spheres of influence include us senior leaders who are not able to pave a road and to open a door for them. One of the things that I often challenge nurse leaders on, particularly in low and income countries, is that we should be, our whole aim should be that our ceiling, if we have been able to achieve something, our ceiling should be the floor for those who are coming after us. So I have been very successful. I have a PhD from Yale University. That should be the flow for the next generation of nursing leaders. It means that you should be able to surpass what we have been achieved, what we've been able to achieve, and what we've been able to accomplish. But for you to be able to do that, we need to be able to walk beside you and not just in front of you. And we need to be able to open doors, and we need to be able to bring you to the table with us. So I want to encourage every nursing leader in this conference today. That is one of the main takeaway. How do we pave a road for a new fraternity? How do we position the Ugandan nurse and the Ugandan midwife to achieve and to be successful? That very much depends on us as leaders to model the behavior that we would like to be able to see, to be able to teach, to be able to mentor, and to be able to run with you. I think that's really, really important. Ambassador Julius Moto said that this is the era of brain gain. It is the first time that I have heard that word being said, and it is quite encouraging for us to know that now we have all of these platforms where we can access knowledge. Look at all of the hospitals that are here today. Lira Regional Referral Hospital, Mbale, Mbarara, Masaka, Fort Portal, to mention but a few. All of those nurses have been able to attend this conference without actually leaving their practice site. So that's one way for us to continue to bring important information to the nurses, because they need this information to be able to change and transform their practice. So with those few closing remarks, I want to thank you very much for safeguarding time to be here. I want to acknowledge all the organizers behind these scenes, all the details that have gone through, all the invited guests that have honored our invitation to be able to be here. We thank you very much, and we hope to see you next year. Thank you very much, and God bless.
Thank you, Doctor. That's absolutely fantastic. And it's a great point to take away. The fact that something from COVID that's become a challenge has actually been a catalyst for change, and distance is no longer an issue. Geography is no longer an issue. Transport is no longer an issue. Our education is right at our fingertips. So thank you for that. So now we're going to hand over to our next speaker, which is Mrs. Elizabeth Pearson, and she's going to be talking about a case for the Uganda Nurses and Midwives Clinical Journal for Advanced Practice. And then after, we're going to move on to a special presentation from the NNC coordinator, Mrs. Catherine Odeke. Thank you very much. Over to Elizabeth. And after Elizabeth's session, we will be doing a brief Q&A session. Thank you. Oh, and one thing while I remember, there is an evaluation form in the chat box. So if you are able to go into there and complete that, that would be very helpful to us. Thank you very much.
Hello. Thank you very much, Dr. Rose and everyone. Can you see my screen?
Yeah, we can.
Oh, thank you very much. So I'm just going to do a very quick presentation on a case for a clinical journal for Uganda. And I'm just going to go through the what, why, and how. The mission would be to provide a relevant reference bank for improving clinical practice, and it would enhance research activity and participation. I don't know if my colleagues are aware that there is actually 251 nursing journals out there and 400 medical journals. So that is a very good for for reference for that out there. However, looking at Uganda in context and relevance, how much of the information out there is actually relevant to our practice and how adaptable is it? There's a quote here from Mr. Charles saying that the details are not the details, but they make the design. So our details in practice really can formulate our knowledge bank. So what would it look like? Would have a relevant information, obviously, which is evidence-based, but also current, because this will be carried out by us in the clinical practice. We have had all those abstracts, presentations over the last 2 days from our colleagues, which was really encouraging, and you could see from the discussion, the comments, the questions, you know, were really looking at how can I adapt this in my own area. So obviously, if you're looking at writing or you know, maintaining a clinical journal, we've got to have the integrity. I think that speaks for itself, that the work should be something we have carried out. We have to be committed. So you cannot start on day one about, you know, looking at maybe, clinical documentation, and because it's really tough, you move on to something else. So we also need to have that accountability. I think how the different hospitals and institutions can come along to help us with that, we can then nudge each other to say, okay, I'm doing this bit, what are you doing? And also be consistent. Consistent is a very important thing, and that would also help us maintain the journal to come and for the young leaders. We would think that with the abstracts that have been presented, I would like to applaud, together with conversation with our announced leaders, that they become the pioneer articles. You know, if more work is done with them, we'll be able, through the leadership of those who have done it before us, guide us in creating a CNG-MU, Clinical Journal of Nursing and Midwifery, Uganda. So those little steps forward. We are here, 2020. It's International Year of the Nurses and Midwives. I think it's a good opportunity to have a kickstart. Yes, despite COVID-19 pandemic, we have been able to, do very good work. The world has put us on the spotlight, an opportunity for us to, approach the stakeholders and see how they can support us on that. So it is a good case for a journal. We could maybe look at having a first publication utilizing the pioneers who have done their abstract over these last 2 days, and formulating what it would probably look like. I think that will encourage more research activities, because I got feedback from, I think it's or Iganga, yesterday, everyone wanted to write an abstract. So thank you so much. Please get pen to paper. We have good leaders. We have Madam Catherine Odeke, we have Dr. Rose Clark, we have our commissioners. They'll be able to guide us, I'm sure, throughout their busy schedules. And then looking ahead to 2020, have subsequent publications. We've got to just start somewhere. So what is the way forward? I think this initiative would require speaking to our stakeholders, obviously the Ministry of Education, the Ministry of Health, and any interested individuals to come along on this journey. It was a very short presentation. Let's go away thinking about it, and appreciate any comments and discussion way forward. All I want to say is, no, it is not as difficult as it sounds. And no, you do not have to be an A-grade nurse. And no, you don't have to have published before. So just like me, we can get on writing. And will I make money out of it? No. I think it will be an opportunity for you to share the research you have carried out, just like our friends have done over the last 2 days. But most importantly is the step, getting you to publish your work, that drive, that motivation of seeing your name against an article published somewhere, I think would really build our self-esteem, which is one of the very useful things that this Nursing Now campaign has brought to us. So thank you so much for listening, and over to you, Madam Catherine Odeke, our coordinator, Nursing Now campaign, Uganda.
Thank you, Pearson, and thank you, everybody. Thank you, all nurse leaders and all nurses and midwives present. I would first of all want to bring the greetings from our Commissioner, Health Services, Nursing and Midwifery. In fact, they have been quite busy, and majority are up country, but she's very happy that this conference is going on, and should have loved to be here to have given her remarks, but because of the schedule of duties that have been put upon her in this very week that that's coming to an end, it was not possible for her to be here, but she sends her greetings to all. Now, to us here in our meeting, Catherine Betty Odeke is my name, National Coordinator, Nursing Now, Uganda. It has been a great, good time that we have had. And indeed, to Nursing Now, Uganda, it has been a strengthening and an encouragement for the campaign. And indeed, it is an encouragement for us to move to June 2021 with all the strength and looking at it and believing it is going to be a strong force. And indeed, by the end of it all, most of our nurses will be appreciating, and there'll be something on the ground to show that there has indeed been a raising of the profile and building of the status of our nurses and midwives. Uganda has the highest population of young people, and this is as well seen in the age group of our nurses and midwives who are entering the training institutions today. And indeed, it takes a lot to think of these young people who have chosen to join the professions of nursing and midwifery. But we are grateful that the Florence 9
I don't know if we could be cheeky and ask Dr. Rose to jump on just momentarily while we see if we can reconnect.
Yeah, I'm back. The network is disturbing, but I'm coming to an end even. We are going to really to have a transformational kind of leadership in the profession. And this indeed will go a long way to bring back a good face to the profession of nursing and midwifery. So what we have seen from here, what we have heard from here has really shown that our young people are people.
Lost her again. Okay, so just while we see if we can reconnect, I'm just going to have a quick look in the chat section and see if there are any questions or if it's more just sort of comments that we've got here. I think mainly it's just many thanks to all the speakers who've taken the time to come and bless us with their knowledge and to encourage us. And I think the phrase that you know, the brain gain rather than the brain drain has particularly resonated with people. I think the fact that you can do it on any kind of smartphone, on a computer, the fact it doesn't take up much memory and allows you to take a certificate, it just looks to be a tremendous opportunity, which I think we should all take advantage of. So let's see, any more? Oh, okay, so I think we've got our speaker back on, so I'm going to hand back over.
Hello? 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 Hello?
Hello, we can hear you.
Yeah, I'm back, but now I've just changed on the. I'm back, but now I've just changed on the. I'm back, but now I've just changed on the. I'm back, but now I've just changed on the. I'm back, but now I've just changed on the. Hello? Hello?
Hello.
Hello?
Hello.
Yes. Yeah, I am back, but now I've changed on the phone. So the weather is not good. I don't know, maybe it's the one affecting the network.
Yes,
the network is affected, but in it all, I was concluding by saying that the kind of leaders that we are really seeing coming up are those that I believe are going to transform our professions of nursing and midwifery. And it will all work out with that good mentorship. And I was saying, it is good when you're a leader, you're a good leader, but your desire really is to mentor someone who will be better than you. And then that next generation will be desirous to mentor the best. And that's how really good leadership works out. And that's how the transformation leadership in anything comes out to pass. So thank you for this time that we have had together. And I'm believing that going back and not sitting, but moving on, hands together, looking at the future, which we should all be hoping is a brighter one. COVID came, and it's COVID which has made us to have such a webinar where we are meeting cross countries and we are meeting beyond borders. So everything has its disadvantage and advantage. And the advantage of COVID-19 has been that now virtually we can meet in different countries and we can still hear one another, understand one another. And I cannot go off from here without appreciating Japaigo. It was nice hearing Johnson speak from that end. And indeed, Japaigo has been a very good partner, very good friend. They have made us feel at home. And for nursing now even to move to the level that we have moved in Uganda, they have been one of the key partners. So I say thank you, Japaigo. God bless you. And to everybody, God bless you all. Thank you.
Oh, thank you very much. Now it looks as if the Permanent Secretary has not been able to make it online just yet. So would I be able to hand back to you just to sort of allow you to officially close our second annual national conference? And we hope that in the next year we'll be actually able to see each other face to face. But whatever obstacles are in our way, if this thing carries on, we won't let that stop us, and it'll be bigger and better next year. We thank all the speakers for making the time to come and speak to us, and hopefully inspired people to be bigger and better. Yes, Mrs. Odek, as the coordinator, we'll hand back to you.
Hello, okay. Yeah, it is indeed also good that really the Permanent Secretary, Minister of Health, is the patron of nursing now, Uganda. and she has stood with us in this campaign right from the time of its inception. And as we have moved at every step, she has been there with us and for us. And we are glad to have, through her, have all the top leadership of the Ministry of Health supporting the campaign. So if really the campaign is to fail in Uganda, it will not be that the top leadership has not been in support, but it will be that we nurses and midwives ourselves would have failed it. But as for the top leadership, we are grateful for all the support that they have given unto us. Finances indeed has been difficult, and that area, even for them, they have not been able, because it should be our very department from Ministry of Health to give us that support. But we still believe that the Lord God who has brought us to this far where we are will still open doors and will cause us to move on for the good of these professions of nursing and midwifery. And indeed, with many things now, as we network, as we collaborate, and not with the limited borders, but all borders open, things are going to work for the better. And it will not only be for Uganda, but it will be for the region. Because when you're right in your home and the neighbors are not okay, then definitely you'll be in trouble, because everybody will look at you. But when you're okay and your neighbors are fine, then you can all rejoice, have times of meeting together, feasting together, and sharing together. And this is the desire that we want to see happen in Uganda. And with those few remarks, on behalf of the patron of Nursing Now Uganda, I now declare our second National Health Conference closed. Thank you.
Thank you, Mrs. Adeke. That's fantastic. Appreciate you doing that. Well, we just dropped that on you at the last second. Thank you. So just a special shout out to all the hospitals taking part. Please forgive me if I miss any. So we've got Hoima, Fort Portal, Lira, Arua, Mbale, Lubago, Mulago, Marara, Iganga, Masaka. Apologies if I've mangled any of the pronunciations. Thank you especially to all the participants for taking the time to come and listen and hopefully get empowered and inspired. And we look forward to seeing you all and more next year for the 3rd annual National Healthcare Conference. Enjoy the rest of your day, and we look forward to speaking with you soon. Please remember to share on all social medias. It's NHCC Uganda 2020. So I hope to see all your posts on Facebook, Instagram, Pinterest, LinkedIn, Twitter, etc. And reach out if there's any handouts or information you need. Thank you very much.
Thank you very much. I'm going to shout out to Mulago, Sister Nasuna. Would you like to say hello? Sister Nasuna, hello.
Hello.
Hello, Sister Nasuna. Thank you, Mulago, for tuning in.
Hello. Thank you very much for the conference. We are really grateful. Thanks for the information you have shared with us. We are so grateful for that. Nice time.
Thank you. I see Iganga. Where is Iganga?
Yeah, is it on?
Iganga. Iganga.
Hello. Hi.
Thank you.
Hi.
Thank you.
Thanks for the conference. We have appreciated and we have learned a lot. Thanks very much.
Thank you, sister. We've got Fort Portal. Hello, Inga. Yay. Thank you very much. We've got Arua.
Yeah.
Hello. Hello, Arua. You can imagine we even got Lubaga Hospital, Sister Krista. Yes, we've got Mbale. Hello, Mbale. Yes, and we've got Hoima. Hoima. Hello, Hoima. Yes, we've got Masaka. Hello, Masaka. Masaka. Have I missed anyone? Barara. Yes. Arua, there you go. Arua, where are you? Arua. Yes. Arua, thank you. Have I got anyone?
Malago Specialized Hospital.
Malago Specialized Hospital. Lira. Say hello, Lira.
On behalf of the HCA, Lira, this is Edson, but
thank you very much. Thank you very much. Dr. Catherine Hanaway. Dr. Catherine Hanaway. Thank you. Mr. Peter Johnson and Japaigo. Okay, Mr. Peter. Thank you so much, Ronald at Sifovid. Thank you, Ronald at Sifovid. Okay, Specialized Hospital. Thank you, Mulago. We shall come back soon. Thank you very much for hosting us last year, and thank you for tuning in. Thank you, Sister Nasuna, and thank you very much. Dr. Our patron. Thank you very much, Mr. Cliff, Penny, Rose, Madam Catherine Odeke. Thank you so much. Really appreciate. I cannot shout out to, but thank you very much, Dr. Amatovu, all the way in. I didn't get the part of US you are. Not very late for you to say hello. Thank you so much. I mean, the floor is yours. I know we thought we would have some networking, but it's really difficult on this virtual platform. But feel free to say something. Let's feel like we are in the same room. Mr. Matthew Pearson, thank you. Thank you, Tracy. Thank you, Barbara. Thank you, Flavia, Jacqueline, Anita, all the people who have endured this platform, Teddy, Harriet, thank you, Newell, Amal, Alice, Alopu, Juliet, Nabosa, thank you, Apio, Jennifer, Sulaiman, thank you very much, Kahunde, thank you, Madam Maima Mutawazi, thank you, Joshua, thank you, Rebecca, thank you, Nawakera, thank you, Winifred, thank you, Joshua. I'm trying to go through all the names as quick as I can. And last and not least, I really want to thank Timothy Ogonkara. Can you please put your video on at Yuka? Yes, that is the man. Thank you so much, Timothy. I really appreciate your IT coordinating of Uganda to stay online and, you know, be connected. Thank you once again. And we hope that you continue keeping safe and that God will look after you until we meet again very, very soon. God bless you.
It was so nice meeting all of you.
Thank you.
Thank you, Dr. Matovu, for being here.
Dr. Rose, I've heard a lot about you, so I look forward to meeting you one day. And thank you, Sister Jemima. Thank you for reminding me about this conference to attend. So It's nice meeting you all. You did a great job.
Thank you. So this is our song. The ICN released a song for nurses. Please enjoy as we log off. Thank you very much.
I have seen you close your eyes. I have held you back from the brink of death, and I want you there now. Because I know that you are aware. Though we are no needs, we're still here to please the most rewarding job on earth.